Dear respected neurosurgeons from across the globe, it is my privilege to welcome you today. This webinar is coming to you from an initiative by DG Neuro, a digital initiative by Health and You. This international webinar comes to you through digital initiative of Health and You, a Health and You company in India in healthcare sector, a joint venture with Newly Company Limited, Japan. We are extremely happy to get associated with World Federation of Neurology Society, its Pediatric Neurosurgery Committee and Neuroendoscopic Committee. We offer special thanks to Dr. Dev Pujari sir, Dr. Nelsi Zanan from Brazil, and Dr. Mohammad Qureshi for giving us this opportunity to carry this webinar. I have now pleasure in handing over the session to Dr. Dev Pujari sir. Thank you, sir.
Thank you, Deepak, for supporting our activity. And I would welcome all the participants and our faculty for this webinar. As you know, we change, well, it used to be every 4 years. It is going to be every 2 years for the WFNS committee now. And the term of our committee would be getting over, or in fact already over. Dr. Nelsi represents the Pediatric Neurosurgery Committee, and me and Moody Qureshi, we represent the Neuroendoscopy Committee, and we welcome you all. I hand over to Nelsi to start the day's proceedings.
Hi, good morning, good afternoon, good evening, everyone. Pleasure to be here. Thanks a lot for your time, and special gratitude to Dev Pujari and Mahmoud for this organization. After 4 years, I'm leaving the chair of the Pediatric Neurosurgical Committee, and is our online bye-bye. I hope we can see you all in Colombia physically. We have the privilege to start this meeting. Do you like to introduce the first speaker, Dev Pujari?
My pleasure to introduce Professor Constantini. Shlomi has been very active and has been one of the founders of the organized neuroendoscopy in this world. Shlomi has also contributed a great deal by forming a group of endoscopy interested surgeons in what was called the International Study Group. And there are quite a few facts that have emerged from collaborative efforts of this group. And I would like Shlomi to have the first talk today on dilemmas in neonatal hydrocephalus, where he would certainly talk about how it developed. Thank you, Shlomi. Your stage is yours.
Thank you very much. Am I being seen and heard well?
Yes, yes.
Okay, wonderful. I'm the first speaker. We have 10 minutes. I would like to run it. I coined this talk, Dilemmas in Neonatal Hydrocephalus. And what I would like to do, I would like just to show you one slide of the formation of the IFNE, which was in Awaji Island 20 years ago. And the role of the IFNE was to serve as a forum for effective communication. And basically, this is what we're doing now. I like to speak about hydrocephalus rather than about endoscopy, because we're treating hydrocephalus and we should be disease-oriented and not technology-oriented. So in some of the types of obstructive hydrocephalus, we have two choices now, ETV and VP shunt, and we have to know the facts in order to make the right decision. So shunts are sort of okay. They're the bread and butter of our profession. Hydrocephalus is not a uniform disease, and shunts have modified hydrocephalus from a lethal disease to a curable disease. But we all are familiar with those disasters that happen with shunts. It took us a while to internalize and to understand that shunts fail. This is from the Kestel study showing that 40% of the shunts failed in the first year. And this is from the Drake study showing that there's not much of a difference between those three valves, the Sigma, the Standard, PS Medical, and the Delta. So the best shunt is no shunt. There is infection, there is mechanical failure, there's seizures, and basically shunts are non-physiological solutions. So when neuroendoscopy kicked in, we really had the hope that we're getting rid of the shunts. The goal was no hardware. So the first procedure, you have a block here, you make a hole here. Also, if you have a block here, what we coin FVOO, forced ventricular outlet obstruction, then in theory, you can also perform an ETV. So what is the data we have to compare between shunts and endoscopy? This is a slide from the best wake-up slide producer, Alfred Aschoff from Heidelberg. So this is when you look at the results of endoscopy, this is sort of a meta-analysis on kids and adults. And these are different series that you see here. And you see this is the difference between Toronto and Paris. Everything in Paris works better. And what is the real thing? And if you compare the Paris and the Toronto Kaplan-Meier curve, you see that the biggest difference is in what we call early failures. What is the reason for early failures? Wrong technique, different selection criteria, different etiology, and too early decision about a failure of an ETV. So when we started to do the international studies, we acknowledged quite early that selection and failure criteria vary very much between different centers around the globe. This is the nightmare of every neuroendoscopist. You get a red screen. We will not talk about it too much, but basilar artery perforation has been described from many centers, including some of the best centers. This is one of my cases. You see here this web in the aqueduct, and this is what I did. I did a hole posterior to the basilar artery, which was ectatic. Nothing happened, but this was an almost injury to the basilar artery. I just overlooked that ectatic basilar artery in the interpeduncular system. Sudden death has also been described in post-ETV. We should remember that patients who undergo ETV are not cured from their disease, and they should be continued to follow. And God forbid, if they have headaches and vomiting, they should come immediately to the emergency room. So in the 90s, and this is from Pepe Cinelli, this slide, shunts and ETV became sort of a valid alternative, and we started to wonder which patients can benefit more. So fact one is that neuroendoscopy came in without any randomized study, and that excluding aqueductal stenosis above the age of 2, the non-infants, all other indications for ETV are still questionable. So we started about 20 years ago to do some studies. This was our first study about repeat ETV. Is it worth doing? And in this study, what we did, we combined 20 patients from 4 centers around the world, showing that the success rate is about 65%. But this was a collaborative study. And if any of you is listening from the participants, do collaborative studies. So when ETV fails after an initial success, it is an option to do a redo ETV if the anatomy is suitable. Next, we move to study if ETV is working in patients who had a bleed or an infection in the past. So this time we took 101 patients from 7 centers around the world. And this is, we had patients who had only infection, those who had a hemorrhage, and those who had an infection and hemorrhage. And we studied the success rate, which are coined on this slide. This is a paper that was published in Journal of Neurosurgery. The next one was the INEBS. Do neuroendoscopic biopsies provide the result we are looking for? This time, we looked at 293 patients from 13 centers around the world to find an alarming difference between the neuroendoscopic biopsy and the final pathology for 78 patients who eventually had an open approach, mainly for the pineal region or posterior third ventricular paper. So this is another paper that was published in Journal of Neurosurgery. So while we were doing those studies, we were looking at the same 7 centers, and we realized that a lot of ETVs were done in these centers. So what Abhay Kulkarni from Toronto did, I think he's here in this seminar, he looked at those over 1,000 ETVs and compared them to over 600 shunts from the shunt design. And for the first time, we coined the term ETV success rate, which is available on everywhere in the YouTube, everywhere you want to be. For the first time, we can sit with a family and give them a rough prediction, would ETV work in their child? Now, what about infants? In infants, the risks and the benefits are large because shunts fail in infants. The younger the baby is, the higher the percentage of failure. Is it more dangerous to do an ETV in an infant for the short term during the operation? Are there more leaks, infections, or are we really converting an active hydrocephalus to an arrested type? So what is in the literature? Again, in Paris, 80% success rate. In the UK, 30% success rate. Look at this case. This baby had an ETV for an aqueductal stenosis. She continued to be on the 99th percentile circumference, the frontal on the full side. She had a nice flow void on the MRI. She had 3 lumbar punctures. So what is this kid? Is it a success or a failure? She doesn't have a shunt. The parents are happy, but did we pay a price in her neurodevelopmental scores due to performing an ETV compared to a shunt? This one is a crazy case. Also, at 2 months, this baby for aqueductal stenosis had a shunt, according to parental preference. At 1 year, he had a block. Then he was revised. Then he had another revision, and then he had an ETV, and he's wonderful now for 12 years following the ETV. So maybe it's better to do a shunt and then convert it into an ETV. Just a perfect kid. So do an ETV, do a VP shunt, convert to an ETV. And this one that I showed before shortly came to me at the age of 1 day with a head circumference of 42. I shunted him. It's over 20 years. He never had a revision, and he's just perfect. So where is the truth? So this is where we coined the IIHS, the International Infant Hydrocephalus Study. We had a steering committee with Spiros Goros, with Abhay Kulkarni. This was a multi-center international RCT on the role of ETV versus shunt in infants with obstructive hydrocephalus. We took only strong neuroendoscopic oriented centers who had experience in infants, who were also committed to the study protocol and to follow the patients for at least 5 years. Newly diagnosed obstructive hydrocephalus below the age of 2 years, full pregnancy, non-infant, ability to follow for 5 years. This is how the patient randomization went, and this is how we looked at the primary outcome measure was the neurodevelopmental score at 5 years. This was done mainly by Abhay Kulkarni. What Abhay did is compose 5 tests, 3 completed by parents and 2 completed by professionals. This was translated to 8 languages, reverse translation to make sure the translation is good. And then we had all the secondary outcome measures that are coined over here. These are the centers and how many patients they've contributed. If you compare the perioperative morbidity, mortality, not a big difference, more leaks, of course, in the ETV group. And this is when you look at the entire group, the Kaplan-Meier of the entire group, ETV 66% at 1 year, shunt at 83%. If you look at those over 6 months of age, 80% for both groups. If you look at those under 6 months of age, you see 58% for ETV and 82% for shunts. So to summarize, when corrected or adjusted for differences in age and history of hemorrhage or infection, the risk of ETV failure was about 3 times higher that of a shunt. So the conclusion for that part of the study was that was a low morbidity for both options. In infants over 6 months, ETV might be a reasonable alternative. In infants below 6 months of age, ETV should be discussed with the parents, knowing that the rate of redo surgery is higher than for shunts. Then we looked at the neurocognitive tests at 3 years and 5 years. So this is what we did. We did the Denver developmental test. This is an elaborate test. We did the HOQ. This is the hydrocephalus outcome questionnaire. You see, these are all elaborative tests. And the HUI, the Health Utility Index. And when comparing at 3 years and 5 years between the two groups were identical. So overall 5 years outcome in this cohort in infants is very good, regardless of ETV versus shunts. No significant difference identified in any of the 5-year outcomes. The postoperative ventricular size did not affect the outcome of our patients. This procedure, this study, the IHS is published in 3 papers that you see here. They can easily be found on PubMed. This is our meeting in September. I hope it will happen. And thank you very much.
Thank you, Shlomi. Well done. The discussion will be at the end. We have the privilege to introduce Dr. Gisele Coelho. She is a Brazilian pediatric neurosurgeon devoted to research in simulation. She has very work on this field, and I got the privilege to share some work with her. And she won the Young Neurosurgeon Award in 2015 in Rome. Please, Gisele, welcome. We are seeing your slides, but not hearing your voice at the moment.
Open your microphone, she said.
Yeah, sorry, good morning. First of all, thank you for the invitation to be here to present this important thing. I will present about training in simulation in endoscopy. And as you know, the impact of COVID in surgical practice is widespread. And the transformation of the operating room routine during months caused a gap in surgical training. Then, the development of surgical simulation platforms is therefore essential to reduce the risk of potentially serious intraoperative errors arising from an experience, especially in this moment. And we know we have some possibilities of training about the use of cadaveric specimens, but they have a lot of limitations. They are not possible to replicate fine operative manipulations. The use is restricted, especially now, and they do not provide a disease or pathological environment. About the animals models, they have a lot of limitations too, especially the poor similarity to human tissue in height, cost, further the lack of reproducibility. And the other method is the virtual reality, but again, the limitations more important is the high cost for this high sprite use, and at the same time they have severe limitations regarding to haptic feedback. And then the purpose of this project is to provide new tools for neurosurgical education that combines the mixed reality, the full 3D virtual reality at low cost and high realistic physical models. And then we developed the virtual models using the program TDS Max. And the physical simulators, they are doing first with 3D print of real patient, second for handmade process using plastic artists to be realistic. And here, the first simulator is the virtual simulation for hydrocephalus, and it's possible to see to watch in the virtual reality step by step of the surgery and to have the 3-dimensional visualization. And for students, so important to have the anatomical, interstructural anatomical relationship well defined to understand and to take care about important structures, for example, the basilar artery. Here you can see on the right side of the video, the basilar artery and the third ventriculostomy. And then this video is to promote the three-dimensional visualization. After to see this video and to see the procedure in three-dimensional way, the student or the resident will go to the physical simulators. And here you can see the first version of this baby in the first phase, and here and the last phase more realistic. The details of the development of the physical simulator, because it was based on a real patient, images of MRI and CT, and the simulator also has the CT interface, then it's possible to perform the CT scan and also to associate the navigation system for the training. Here you can see the choroid plexus, the veins, and here the mammillary bodies and the third ventricle floor, and it's possible to simulate the third ventriculostomy. And with this baby, we can see to the basilar artery, and if we have some kind of lesion, the basilar artery will have the bleed effect. And here we can see the basilar artery and the branch with bleeding effect. Is extremely realistic. In this baby, we have the tumor in the pineal region, and it's possible to perform the biopsy. And again, the bleed effect. This is important because the trainee here can simulate also the emergency situations. And here it's possible to associate the ultrasonic aspirator and to do the complete resection of the tumor. And here the fourth ventricle, this model, it's important too because it's possible to visualize and to have the three-dimensional of the fourth ventricle. And it's possible to use not only the rigid endoscope, but also the flexible one. And we developed the craniosynostosis simulator model for training endoscopic approach. And here we can see the superior sagittal sinus, and it's possible to simulate the bleeding effect too. And here, the simulator has been using in the IFNE course and to train the neurosurgeons new technique for craniosynostosis endoscopic correction. Here you can see the simulation in the operating room with Dr. Hinojosa in Spain. And then here with all the step-by-step, and it's possible to simulate, and also if any kind of lesion in the superior sagittal sinus, we have the bleeding effect. These simulators, virtual and physical simulator, are completely evaluated for expert surgeons, and then they were approved to be used for non-experienced surgeons. Here we can note in this paper the reduction of the learning curve in the survey. We note that after 6 tentatives, 6 procedures, we have the reduction, significant reduction of number of errors after the training of physical simulators. And here we are using for some courses in Brazil, international, because the virtual simulation, for example, in the first part of the training, provides varying degrees of immersion, realism, the perception of physical reality, symbolic, geometric, and dynamic information, provide the detailed interstructural and anatomical relationships with multi-angular vision, and the simulation of surgical steps if we reach three-dimensional visualization. And about the physical models, they are extremely important because they have anatomical reproducibility, pathology, expression. It's possible to use the real tools. and also CT compatible, no ethical objections. All surgical steps can be trained, including the emergency situation. And we have the evidence level 1 that the use of the simulators improves operating room performance. And to combine the virtual and the physical simulator, we can note the powerful psychomotor and cognitive apprenticeship combining these tools and improving and shortening the learning curve for learners with no previous experience, and most important, in a safe manner. Here's some publications about the issue, and it was a big honor for me to have this Young Neurosurgeon Award for WFNS. Here, another papers that it's possible to demonstrate the reduction of the learning curve in a safe way. And we also published a book with Dr. Nelson, and we have the first book from simulation to practice that emphasizes the importance of the simulation in this training, especially now in the pandemic. And as a conclusion, we have the mixed reality simulation can contribute for improving the anatomic understanding. It must be applied for the best performance and the widespread in surgical training. Here, just to finish, we created a course in Brazil, the first one with mixed reality simulation, mixed platform, and we use the virtual simulation, we use the physical simulation, we use the navigation system. Then the simulators where we perform the CT scan of the simulation and the simulators, and the residents could train step by step of the surgery in the first module. Here we have the model also for cranial synostosis. And the second model was possible to emphasize the concepts. The residents were able to train, and we also evaluate the learning curve in these two models. The results of this training of the residents, especially considering the skills, the practical skills, was really, really impressive. And then we have, I think, and I strongly believe, especially in this period, that we don't have enough training in the pandemic period. There is almost 3 years of gap in surgical education, that the simulation will be extremely important in this context. And here we use it to the augmented reality and to emphasize the importance to understand the anatomical interstructural anatomical relationship. And I would like to thank you, a team that was possible to develop this kind of simulations. It's extremely important, the participation of all. Thank you very much for your attention.
Thank you very much, Giselle. Excellent. The discussion will be at the end. Del Pujari, are you there to introduce the next speaker? If not, yes. Thank you.
Yes, it's my pleasure to introduce Stefan Wulsberger from the University of Vienna, who's taking over as chairman in Graz in a short while. And he's also taking over as the WFNS Neuroendoscopy chairman. Stefan is going to talk about neuronavigation and how it is used in ventricular neuroendoscopy. Stefan, please.
Yeah, Chandra, thank you very much. Thank you very much for the invitation, and really thank you very much for pushing this committee forward with a lot of meetings in the past 2 years. So my topic is navigation in cranial endoscopy, which could also be called a recipe for complication avoidance. And it is all about passing a bullet-sized endoscope through the brain. And in order to pass it only a single time, we have created standard entry points, as you can see here. I think you all know that in ETV, we want to be at the coronal suture. We want to enter 2.5 centimeters lateral to it to reach the premolar membrane. If we want to reach aqueduct area, we come further anterior, 6 centimeters anterior, and 2 centimeters lateral, and so on. So we know all these standard entry points. However, we must not forget that there are considerable individual variations, and these contribute to the not insignificant complication rate of ETV, which is mostly reported, but of course of all other ventricular endoscopic procedures. And most of them, when it comes to mortality, actually are due to bleeding from basilar artery rupture. So I would like to start my talk with a case that I like to show, because we really some years ago tried to invent an increased caseload of ETVs, also in an emergency setting. So this was a case of a known oligodendroglioma in the midbrain, as you can see here, with this calcification, who presented at our emergency department in the middle of the night with a subacute hydrocephalus. So the consultant who was on call actually considered him as an experienced endoscopist, did the ETV, but he could never find the ventricle. And after some attempted passes to the ventricle, he stopped and he went to the CT scan, and this is what you could see. So if you see my mouse pointer, then you can see that there is a hemorrhage on the contralateral thalamus, which means he had passed the endoscope much too far inside, much too deep. And obviously he pushed away the ependyma in front of his lens into the contralateral basal ganglia, as you can see here. So finally, this patient ended up with a shunt, but because he had a bilateral lesion, he remained in a vegetative state forever. So this is a massive complication, and we had 2 of them at a short period of time. So we thought we have to improve our way of doing ETV. And here you see the problem. This is just for illustration. We pass the endoscope through the white matter, and we are blind. At this moment, we're completely blind. And if we don't know exactly where to target our area, our target point, we may create significant damage. I don't want to go further in this video. So at that time, we did a retrospective analysis how we did ETV without navigation. And we collected 59 cases and checked 3 trajectories in all of them. So first of all, we reconstructed what we did, so a manually planned trajectory, because we thought we do an individual plan. You see that in blue here. Then we compared it to a fixed burr hole, as you can see, to 25 or 30 millimeters at the coronal suture. And then we wanted to know if navigation will have any impact, if it will be any better than the other 2. So this is how we performed ETV at that time. So we had still the foils of MRI. We measured our perfect entry point, and we translated it to the patient with a ruler. So we recreated this because we had the entry point, of course, from the post-op CT scan. We created this entry point, and then we compared it to the fixed burr hole trajectory. You see here, we took a 30 millimeter lateral on the coronal suture burr hole. Okay, and then this is how we decided to do navigation. So we said we will define, like in a biopsy, a target point, which is in fact just posterior to our clivus and anterior to our basilar tip. Then we will do a waypoint, or let's call it an entry point, in the center of the foramen of Monro. And then you can enlarge this line, and you can enlarge this line to the surface of the 3D model of the head. And there you can reset the entry point, and you have an exact trajectory, like in a biopsy, through the foramen of Monro to your target point. And we evaluated the position of the entry point, of course, and then the distance of the trajectory to the foramen of Monro, and especially to the fornix, of course, anterior medial, and to the thalamus on the lateral side, and then in the third ventricle to the wall, to the thalamus and to the hypothalamus, in order to understand which is the best method. So you see here, well, easy in red, the standard burr hole, 3 centimeters lateral on the coronal suture. You see the manually planned on the left side, the gray spots, the individual burr holes that we did. And on the right side, you see the navigation plans, which are quite a bit different. And it seems they are a bit posterior, at and posterior to the coronal suture. And here are another results. You see the navigated burr hole, it was between -2 to +3 centimeters posterior to anterior of the coronal suture. Whereas in the manual technique, it was typically anterior. In the fixed burr hole, it was at the coronal suture. But what is most striking, the trajectory displaced the fornix never in the navigated procedures, in 50% of the cases in the manual planning, and still in 25%, 27% of the fixed burr hole. So in fact, the best would be the navigated technique, and the second would be the fixed burr hole technique. So with this in our mind, we went on to design a navigation protocol, and we wanted to use EM navigation because we have heard about this so-called stylet that you can pass inside the endoscope. So here this is what we started off with, the optic tracking. I think you all know this is a Esculap endoscope with the optic tracker on it, and you can of course track the tip of the endoscope with this. But of course you cannot track the position of your puncturing device. Here's electromagnetic navigation. Electromagnetic has some advantages because, first of all, you don't have to pin the head, which I think is especially important in children, of course. You can use these trackers. Yeah, we don't use invasive. We always use skin or even nasal trackers. And here are the pointing devices. And you can use this dedicated wire to pass into the endoscope. So these are some pictures how we did it. You see, we passed the wire into the endoscope, and then we advanced the wire to puncture the floor of the third ventricle. Here's a recent publication of our nasal tracker. You can see we put this tracker into the nose of the patient, yeah, and thereby we don't have to pin him anymore. This is very, very practical, really. So with this recipe, we went on to clinical application, and we published this after 16 cases. And I think most strikingly, you saw we never touched the fornix in these cases and never the hypothalamus and thalamus. So this is the publication from Journal of Neurosurgery at that time. And at that time, we concluded that navigation optimizes the distance of your endoscope path to important structures. And most importantly, we never had to do a second pass. I think this is very important. So to summarize again, how do we do a third ventriculostomy now? How do we plan it? We set a target point. Then we set the entry point in the center of foramen of Monro. And then we reset the entry point at the 3D surface. And with this, we adjust the trajectory according to sulci and vessels, because of course we don't want to go transsulcal and not pass any vein or artery. And then we note the burr hole relative to coronal suture. You see here, 0.5 centimeter posterior, 2.5 centimeter lateral to the coronal suture. And either you use navigation itself, or you could theoretically also paint it on the head. Well, this is, for example, a posterior third ventricular lesion that we wanted to biopsy. Again, we set the target point, set an entry point in the foramen of Monro, and then we reset it at the 3D surface, and we know exactly where we enter. With our friends from Brazil, Carlos Brusius, we published a paper that shows a combined burr hole for posterior third ventricle and endoscopic third ventriculostomy. So this is also a possibility. Okay, just some cases. This is one 20-year-old male presenting with a pineal region tumor. So hydrocephalus, as you can see, here is the lesion in the posterior part of the third ventricle. You can see here as well. Also, there's some thickening of the pituitary stalk. Yeah. So first, we did an endoscopic third ventriculostomy. Here you see the plan that I just showed you. So we just enter the ventricle, and in front of our endoscope is immediately the foramen of Monro in the center. It's a biopsy, yeah, and you are always about some millimeters accurate. So here's the third ventricular floor, and of course, if you just pass straight on, you will find your exact target area. Then we use a stylet. We advance the stylet. It has a blunt tip, and we can do a navigated puncture of the third ventricular floor, as you can see here. And through the same hole, it's easy to pass a Fogarty catheter to enlarge the hole. And of course, then we check, as always. And when you then remove your endoscope, you see that the fornix is virtually untouched. And I think this is the whole concept. In this case, we did CSF check for tumor markers. They were negative. And you see that's the post-operative MRI. You see the nice flow void at the hole. And here you see that finally we had to do another biopsy of the pineal region tumor. So now we went for a second burr hole. I'm a fan of 2 burr holes, honestly. It's much less invasive than doing a mid-angulated single burr hole. So again, we did our calculation on the navigation. You see, foramen of Monro is quite small. Now, yeah, we enlarge it with this obturator that is provided by the Lotta endoscope, and we change to the standard Lotta 0 degrees, as you can see here. Yeah, and we take biopsy. And what I wanted to show you is when we remove our endoscope, there is virtually no touching of the fornix, as you can see here, no damage at all. So this is perfect trajectory. Actually, these are his images after radiochemotherapy. He was proton irradiated. Yeah, that was a germinoma, of course. There's one last case I would like to show you, a multifocal ventricular lesion. One of our hospital engineers with some headache for 3 weeks, and diabetes insipidus, also oculomotor palsy. And you can see these are his images. There's one larger lesion in the area, well, of the stalk actually, and of the lamina terminalis. There's another one here in the pineal region. And if you look carefully, there's also another one here at the obex. So at all areas where the blood-brain barrier is open, you see these lesions. And of course, immediately we thought, well, could be a germ cell tumor. This is just to show you. Actually, that's a video prior to COVID, as you can see on my nose. We do, again, a ventricular puncture first, navigated, then remove CSF for tumor markers, and we fill up the ventricles again. And here's the problem now. Here we pass our endoscope, but you see if you're navigated, you pass it along this line, and you are completely sure that you will enter the ventricle, as you can see here. Again, the foramen of Monro is quite small, but if you have the perfect trajectory, you will not create much damage. So here we are inside the third ventricle. You see the floor is very distorted, very strange, very thick floor in the anterior part. Now we are using a biopsy forceps and removing part of, in fact, the floor first. The pendula is on top of the lesion is underneath, so we coagulate a bit, and then we take our biopsies without problem. Very avascular lesion, in fact. Yeah. And what I wanted to show you, when we retract the endoscope, you can see again very untouched fornix. Histology, it was a B-cell lymphoma, and he got on chemotherapy, and that's a current image. This is one of my last slides, a project that we have now together with Uli Tumale, with the European Union grant, to develop our robot into an endoscope holder with a remote control, doing very small and subtle adjustments of the endoscope once in the ventricle. So with this, I wanted to show you that it is actually possible to do a very, very individual planning, just like a biopsy, to reach your target without multiple passes of an endoscope. And I think this is a very safe way of preventing disaster in endoscopy. Thank you very much for your attention, and thanks for the invitation.
Thanks, Stefan. You have used the electromagnetic technique quite effectively and showed the accuracy as well. We have some time for discussion now. I will start asking questions to you first. Does the do the instruments which you are using for either coagulation or for biopsy, do they interfere with the trajectory or your navigation when you are using the EM?
Yeah, very good question. The instruments actually don't interfere. What we found is that all metal interferes. Yeah, so a metal OR table, a metal head clamp, of course, and a metal horseshoe headrest interferes. Yeah, so you have to place your magnet on an upper position, and you have to either stick your EM tracker to the forehead, or what we do is into the nose. I think that's the most accurate we could show. And we're doing this in all children now. Yeah. If we do an endoscopy, we place the head tracker into the nose, and we know this is submillimetrically accurate. Yeah, works perfect.
That has worked well for you. Great.
If I may comment, Chandra, if I may comment here, I'm a big fan of using navigation, but there are two things I would like to say. The navigation in endoscopy is mainly in order to choose the best entry point and the best trajectory. Once you're inside the ventricles, you go by anatomy. You don't choose where to do the hole in the floor of the third ventricle by your screen. You choose it by the way it looks anatomically. That's crucial to understand. The other thing is, I'm always hesitant to introduce and to speak about very advanced technology where some of the people in the crowd may not have it. So I think people should not think that without navigation, you cannot do endoscopy. There are a few things which are very basic. How you position the patient, to calculate and do measurements in order to choose the place of the bear hole. This is really, really crucial, to leave the ear and the eye open so that you can insert in the standard trajectory you scope. And if you don't get the ventricles, take everything out, put a ventricular catheter, and just do with a small caliber ventricular catheter an insertion. Once you get CSF, blow the ventricles, and then put the larger caliber scope or peel away or whatever you have.
Yeah, I fully agree, Shlomi. Yeah, definitely. Yeah, I think individual planning will at least give you the perfect entry point. Even if you don't have navigation, you have the perfect entry point, and then use the ventricular catheter. Yeah, because of course it's much less dangerous if you have even two passes of a ventricular catheter. Yeah, sure.
Thanks, Shlomi. The question on your paper I would like to ask is that you have shown the study, especially the 5-year study now in neonatal hydrocephalus. What is your current practice in terms of sort of advice to a family? At what age do you feel it is safe enough to advise them favorably for a ETV?
Right. So actually, yesterday I shunted an aqueductal stenosis who was 1 month old. Okay. I talked to the parents. I told them it's not that there's no option of doing an ETV, but the success rate is low. I've shown in the paper the over 6 months and below 6 months. But if you go below 2 months and 3 months, the success rate goes further down. So if I have a case of a big head, big ventricles in a very young infant with aqueductal stenosis, I would offer the family first to do a shunt. When and if the shunt fails, you may consider transforming it into an ETV.
Outside of this study, Tomita's group has shown the 3-month kind of mark to show 50% plus and 50% minus kind of success rate. You think that 3 months may be a good marker?
Yeah. You see, the other thing is you have to see what are the results of shunts in your department. If you have a 20, 30% infection rate with a shunt, as still exists in many places around the world, your motivation to get an ETV without a shunt goes very much high. If you have a 2-3% shunt infection, like happens in many of our departments, plus the shunts go puck in and out, then the risk of a shunt is not that bad. I don't say that the shunt is good, but it's not that bad. And then the balance of having an ETV, maybe a leak, maybe then lead to a shunt, it's too much pain. So yeah, 3 months I would not offer, and below 6 months I would tend to do a shunt, but this is my own bias. It's not that an ETV is not an option.
Thanks, Shlomi. Giselle, I would ask one question and then hand over to Nelsie. You have developed wonderful models for many procedures. I would specifically like to ask you about the ETV model. We have, I'm sure you must have read about it. We have developed a dynamic model where you can actually see the floor not only pulsating but also flapping after the opening. Have you tried that kind of a maneuver or that kind of a technology in your models?
About sorry, can you explain?
We developed a dynamic stimulator, which for some reason we have not been able to bring it out of our lab, but where we have actually been able to give a dynamic feel that the CSF pulsations can be seen when you actually puncture the floor. Have you tried that kind of technique in your... it gives you not only the general feeling, but it also gives you a haptic feedback of perforation.
Yeah, it's possible to do. And in this case, for physical simulator, you can use it, for example, 50 times to perform the third ventriculostomy. And the material, they have the property to, in a certain way, to come back to the original position. Then you can use many times without the need to change to replace the model. That is a good thing. For example, our courses that we did in Brazil, each resident could be able to do more than 10 times without damage the model. It's a little bit tough than the reality, but it's possible to train many times. That is the point that we have to develop better this material, right? Not too tough, but at the same time, not to damage.
Nelsie, please take over the discussion and start the next session afterwards.
Yes, we are ahead of our time. We have Padayashi and Moody with raised hands. There is only one question on the audience that doesn't answer. For Shlomi, did you believe that benign intracranial hypertension, ATV, is useful or not?
No, not.
Oh, okay. Thank you very much.
Short. I keep it short. Okay.
Okay. Okay, thank you. Just 1 minute, Padayashi and Mahmoud, just to continue, because we have more than 5 minutes ahead of time. Please, welcome.
Stefan, excellent demonstration of the value of neuronavigation. The question that comes to mind, particularly where you have a small foramen of Monro, does it cross your mind that the fact that once you puncture the ventricle, your coordinates are likely to change, and then your navigation track is also going to therefore change? Does it cross your mind that that might influence whether or not the smaller fornix, foramen of Monro, the fornix could be damaged in that? I know it hasn't been shown in your study of 59 patients, but does that cross your mind? Because the coordinates do change once the ventricles have been punctured.
Yeah, correct. Of course, we always fear that CSF loss causes inaccuracy, but because it's quite in the center of the head, we didn't find any problem, And I think the beauty of it is that you do, like a biopsy, you do a trajectory, like an ideal entry point, target point line. And if you move along this line and everything comes together a bit closer, well, then your foramen of Monro may be a bit smaller, but you will still be in the center. Yeah. So I think we have never experienced a problem with this. If we see small foramen of Monro on the MRI, we would use a pediscope, and you can still navigate the pediscope perfectly with the stylet. Yeah.
Thank you. Padayashi, your last minute.
Thanks. Yeah, I'll be very quick. So thanks, Modi, for bringing up that point. It was exactly something I was going to ask. You always need to check the size of the foramen of Monro on the MRI scan, which you do, obviously, Stefan. And then the group in Liverpool, and I think Uli Tamale as well, published about using the navigation tip as an actual fenestration tool, to counter the question that was asked earlier about whether it influences navigation or not. Just maybe a quick comment on that, Stefan. And then in complex hydrocephalus, I think the Israeli group as well published using intraoperative imaging. They use the MRI scan to augment, changes in CSF, which is great, but it's, not everybody has intraoperative MRI. So we've augmented that and published the stuff as well. We're using intraoperative ultrasound. Do you find anything kind of real-time updating useful, or do you just stick to navigation, Stefan?
Yeah, very good point. Well, you know what intraoperative MRI update means, and we have one. Yeah, it means an hour of longer surgery. Yeah, so if you have a chance of using a burr hole or a transfontanella ultrasound, it may be much better, of course, to check where you are. We haven't done an intraoperative ultrasound update of the images. Especially because we're using the Medtronic navigation and we don't have this possibility. But at least in the multiloculated hydrocephalus at the beginning, I think you're well accurate to do the first cystostomies. I'm not sure about the later ones. Yeah.
Thank you very much. Just a final reminder before move on. We are talking about high technology and is not available in many parts of the world. And you need to use when is available, but it's important to training anatomy and to know, because most of the time is not available for the young neurosurgeons in the part where we have more children below the Ecuador line. Thank you very much for this wonderful session, excellent discussion. And I have the privilege to introduce the next topic, hydrocephalus. We'll share by Suresh Shankla and Sergio Valenzuela. Both leaders not need introduce, they are well known. Please welcome, and the stage is yours.
Thank you. Hello. Nice day. Yeah. Sorry, please go ahead.
Hello.
Yeah. Please go ahead.
Do you start or I?
Oh, okay. Okay. Let me invite the first speaker. Before I do that, let me thank Nancy and Dr. Dev Pujari to really organize this nice webinar today. And I'm so glad and so happy to be present here today. Our session is on pathologies of hydrocephalus, and I would like to invite the first speaker, who is our good friend, Samir El-Baba. I don't think Samir needs any introduction, but I must tell you he is one of the leaders of pediatric neurosurgery as well as the endoscopic neurosurgery, and his work in the antenatal and intrauterine surgery has been well known to all of us. Let us hear him today. He's going to talk about ETV in pediatric spina bifida population. Samir.
Dear sir, can you hear me well?
Yes, sure. Thank you. Go ahead, please.
Good morning to everyone. And it's a great honor to be here on this webinar. And I want to start by saying it was an honor to serve in the last 4 years on both the WFNS Pediatric Neurosurgery Committee under the leadership of Nelsie and the Neuroendoscopic Committee under the leaderships of Professors Diopajari and Qureshi. It was a great honor to work with you both in the last 4 years, and we wish great luck for the new chairs and the new committee members. The topic I'll discuss today is on the ETV in pediatric spina bifida population. This is a controversial topic. I'll try to summarize in a few minutes what we know and what we do not know. Spina bifida, as we all know, is a global disease. All of us deal with spina bifida all the time, specifically myelomeningocele and its severity. The standard of care worldwide remains to perform postnatal repair in the first 48 hours, but we can see there are different severities in myelomeningoceles or myeloschises, and this will impact the future of those kids, as we know, in regards to hydrocephalus. Chiari type 2 malformation or hindbrain herniation is very common in almost all patients with open neural tube defects, and the risk of associated hydrocephalus ranges between 60 to 100%, primarily around 80%. But we all know that the higher the lesion, the higher the risk of development of shunt-dependent hydrocephalus. But spina bifida is not only about hydrocephalus and shunts. Spina bifida is a lifetime disease that impacts motor, cognitive impairments, many social and emotional challenges, bladder, bowel incontinence, sexual dysfunction, and many other challenges those patients deal with. When it comes to shunts, there is no need for me to introduce the complications with shunts we deal with. I fully agree with our friend Shlomi that we have to always think whenever we decide about an ETV, we need to think about our local complication rates and shunt outcomes and in our own departments. Going back to the 1990s, ETV remains started to become a controversial topic in the treatment of hydrocephalus in spina bifida population. Most of the controversy comes around the pre-pontine cistern development, as well as the outlet of the fourth ventricle in patients with spina bifida, and the impact on high failure rates in ETVs. For instance, the patient on the right side has a spina bifida. You can see there's a very good anatomy for an ETV, and you can see the ETV here, it's open, and it remained open for 5 years. While here on the left side, this is also spina bifida, that ETV may not be a good choice. So we can't be generic and say that ETV should be tried in every patient. We should look at the anatomy very carefully. And like, for instance, in this case, I don't think ETV is a good choice, and a shunt is the way to go. The literature is so busy with a lot of data looking at ETV outcomes and lots of arguments against it or supporting it. A large series from our friends in Lyon in France looked at almost 8 years of data looking at 97 patients with spina bifida, and they found that the shunting, the successive ETV is in the range of 70%. And I like the way how they summarized their group. They looked at ETV alone versus ETV CPC. We'll talk about in a minute, versus ETV with concomitant shunt. And those are different strategies that you need to tackle very carefully, depending on the anatomy and the age of the patient. Obviously, the ETV success score by Kulkarni and colleagues has been very instrumental in helping us as neurosurgeons, having good conversations with the parents. Now here, when we look at the myelomeningocele, which supports a lower success rate in ETV, according to the score, I do believe this in the future probably will get adjusted, since now spina bifida is treated differently in different places, including the option of prenatal repair. Professor Worf and the colleagues in Uganda did a wonderful work telling us how ETV and coronal plexus colorization in Eastern Africa was shown to be more successful than ETV alone in infants younger the age of 1 year. This was in general. But when they looked specifically at patients with myelomeningocele, in over 100 patients, they found that ETV CPC appears to be successful and provide more durable treatment than shunts in that patient population. then the controversy in North America started about, can we mirror or have similar outcomes similar to the African studies from Uganda or other places in Africa? Can we have similar studies in North America? And actually, the Hydrocephalus Clinical Research Network did a prospective study, look at ETV CPC in North America, and found some favorable outcomes, but many unanswered questions. So also the other topic is about the ETV and CPC, which is better, a rigid endoscopy, like in this case. This is a patient with spina bifida showing the CPC on the right side, the ETV, and then going to the opposite side and showing the CPC. The question is, are we missing some component here in the temporal horn? So that's when flexible endoscopy came into play, and the WARF group from Uganda published beautifully about the use of flexible endoscopy, and there's some data coming out comparing flexible versus comparing it to rigid endoscopy, and found actually that in general, flexible endoscopy can give more favorable outcomes when we look carefully at the percentage of the choroid plexus we're able to coagulate, and the goal is to be over 90%. I had the pleasure to visit and spend time at Cure Children's Hospital in Bali, Uganda, where I personally learned the flexible endoscopy from colleagues there. There are two types of flexible endoscopy. You have the, here you can see we're looking at the aqueduct, the fourth ventricle, going back now into the floor of the third ventricle in front of the basal-bifurcation. You can see this is post-hemorrhagic hydrocephalus. The technique done there with a flexible fiber optic endoscope is to do the coagulation followed by the puncture into the pre-pontine cistern. And this technique, and also they don't use balloon. Here in North America, most centers use flexible endoscopy using the digital flexible endoscope. Here, one of our recent cases with showing with the digital, you can have better picture, but there's also some challenges with the digital flexible endoscopy doing the CPC. The most exciting thing happening now is the ST trial. Many unanswered questions and controversies will be resolved hopefully in the next 5 years. The ST trial, which is a prospective randomized trial comparing shunt to ETV CPC under the age of 2 years. You can see the date here, January 2022. The last version of this ST trial came out just last week. Our center here in Orlando is privileged to be part of this prospective randomized trial. We already started randomizing babies in the last 4 months. The criteria avoids post-hemorrhagic hydrocephalus, but it worked for spina bifida as well as aqueductal stenosis, as well as post-infectious hydrocephalus. The criteria are very rigid, and I do believe there is good momentum from different centers in North America with enrollment. And those patients are followed in the next 5 years with very aggressive neurocognitive testing at the age of 3 months, 1 year, 3 years, and 5 years. And we believe in 5 years from now, hopefully we'll come back hopefully with some answers from this trial organized by the Hydrocephalus Clinical Research Network and funded by the NIH. The technique we're using flexible endoscopy, we use the lateral position similar to the Uganda experience. Many of you have heard about the option of fetal surgery, prenatal surgery, studied in the MOMS trial, which was published over 10 years ago, showing significant reduction in the hindbrain herniation and reduced in shunting rates from 80 to 40%. And the take-home message from the MOMS trial is the lowered shunting rates and improved hindbrain herniation when spina bifida is repaired in utero under 26 weeks of gestation. A follow-up study came out 5 years ago, showed that severity of ventriculomegaly prior to fetal surgery does impact the rates of shunting, and in our series, also the ETV. We published around 4 years ago our first 60 cases looking at in utero spina bifida repairs and the ETV outcomes in this group. And we followed very meticulously the criteria, inclusion-exclusion criteria of the MOMS trial. all those fetuses, they have lesions between T1 and S1, and they all have hindbrain herniation, and they all are between 19 and 26 weeks of gestation. After the spina bifida is repaired using multilayered closure, the babies are weeks. We wait until they're born around 36 weeks. There's a risk of prematurity, obviously. But after they're born, we monitor carefully the hindbrain herniation and the status of the ventricles. This is not a good case for ETV, but this is a patient with prenatal repair of spina bifida who's good for ETV. So the controversy comes into, should we try for every patient? In our practice, we're literally trying ETV CPC for every patient with good anatomy. And the age, our data show that the age of 4 months is the most optimal for trying it. In many patients who had fetal surgery, you find the floor or the fourth ventricle to be very favorable. If there's a secondary membrane, this should be also taken care of, and also fenestrated, and having an excellent communication with the pre-pontine cistern. And we see here a decrease in ventricular size, and it's important to follow those patients long-term with neurocognitive outcomes. Nowadays, we do flexible endoscopy in all cases for ETV, CPC, but for the sake of time, we'll keep moving. How about the floor or the third ventricle in patients with spina bifida? There are some challenges. You can have a lot of interthalamic adhesions. In our experience, we have been able to successfully get the ETV done safely in all patients. Some of them, they have normal floor. Some of them have interthalamic adhesions, and you have to do the stoma anterior to the adhesion or posterior to the adhesion. Here, also posterior to the interthalamic adhesion. In some cases, if you puncture through or cut the interthalamic adhesion, all studies have shown that there are no long-term outcomes. It is very important after the ETV to think about putting a shunt. Anytime you see concerns and developmental delays on Bailey's testing or other neurocognitive testing, obviously progressive ventricular megaly, macrocrania, or new serence. When we look at our shunting rates, the MOMS trial for fetus surgery have 40%, our Sears in St. Louis, 27%, and now in Orlando, our numbers are down to 22% because we're doing more ETV and CPC. And now being part of the prospective randomized trial, hopefully we will have solid answers in the next 3 to 5 years. When we specifically looked at risk factors for failure in ETV for the spina bifida population, the risk factors were very similar to other published series related to age under 6 months. The question is, should we try for every patient? And the answer is no. This is maybe a good case, but this is not a good case. And you should think about how you trust your gut feeling and trust your knowledge of the anatomy. In conclusion, ETV is considered a reasonable alternative treatment for shunting, depending on the anatomy, considering the age, the status or severity of the hindbrain herniation, if there is a fourth ventricular outlet obstruction, your personal experience, and as Shlomi said, also your local shunt outcomes. Patients who have prenatal surgery, in my opinion, are a different group of patients, so we should be more aggressive about ETV or ETV CPC on them, given their improved hindbrain herniation anatomy. The ETV success score, in my opinion, all of us should use it as much as we can when we talk to patients' parents. And this success score likely in the future would get adjusted as prenatal surgery is becoming available in different countries around the world. And the role of ETV CPC that has been beautifully proven in Uganda and other parts in Africa, we should be patient for the next 3 to 5 years until we get results of the prospective randomized trial, the ESTE trial. Thank you so much and have a great day.
Thank you. Thank you very much, Samir, for this brilliant presentation. And we would take some questions. Yeah, Moody. I see your hand raised. Moody. I think he's not there. Anyone else has any question or comment for Samir?
congratulations, Summer. When you are talking about progressive macrocrania to indicate surgical treatment, or you do ATV or VP shunt, how is your standard deviation to accept macrocrania? Time to time, we have tolerance bigger for endoscopy and less for VP shunt, just to have your advice. And congratulations again, fantastic.
Thank you, Nelsie. Macrocrania is not enough to use it as a one objective point. We should look at the patient as a whole. The progression of the head circumference and the curve, bulging fontanelles, plain skull sutures, and ventricular size. Sometimes we negotiate with ourselves, we negotiate compromises, trying to push the patients towards the age of 3 to 6 months to get the higher success rate for the ETV. So I am willing to tolerate some macrocrania, even if the head circumference goes above the 98th percentile, if the patient is asymptomatic otherwise and doing okay, in order to hopefully get better outcome from ETV or ETV CPC. Macrocrania by itself does not stop me from being more patient, but if macrocrania or progressive macrocrania is combined with progression in the ventricular megaly, that's a red flag that should be treated.
Summer, I have a question for you.
Yes.
How long do you wait in between your prenatal surgery and the day that the baby is born, and when do you indicate the ETV? Do you have a planning for, let's say, 1 month, 2 months? What are the factors that you take in mind?
So absolutely. So obviously, all patients who go through prenatal surgery, we hope that the pregnancy will last up to 37 weeks of gestation for an elective cesarean section, although the average gestation age for birth is around 34 weeks. Now, after birth, 95% of the babies who have fetal surgery after birth will not need a shunt in the first month of life. That's our experience. Their hindbrain herniation improved. And for us as neurosurgeons, this is great because this will give us some time that even if we see slow progression of the ventricular size or head circumference, this can push us towards the range of 3 to 4 months. Our published data for the first 60 cases of fetal surgery, looking at the ETV outcomes, showed that the age of 4 months is very critical for a better ETV success rate. But hopefully now with the ETV CPC, the numbers will be even better.
Yeah. Well, I agree exactly. I think we have to wait a little while to see how the hydrocephalus is going on in the first 2 or 3 months. So I agree absolutely. Congratulations, great presentation and great experience. Keep on going. We'll see you in next meeting.
Thank you,
see
sir.
Your result. Okay.
Thank you, sir.
Suresh, shall we go on?
Yes, please invite the next speaker if you.
Okay. Well, our next speaker is Dr. Nishiyama from Japan, and he's going to talk us about the current status of ETV in obstructive hydrocephalus. So, Dr. Nishiyama, you can go on. Kenish?
Thank you. Can you hear me?
Yes, perfectly.
Thank you very much. Good morning, good afternoon, and good evening, everybody. This is a really great pleasure to be in this familiar team and having the time to talk today. So thank you, Nelsie and Chandra and Moody. So my talk is about the ETV in so-called obstructive hydrocephalus. According to classical bulk flow theory, CSF flow was considered one way from the choroid plexus in the ventricle to the subarachnoid space via foramen Luschka and Magendie, then absorbed into the arachnoid villi or some lymphatic systems, for example, located at the Cleveland-Form plate. Many pioneers considered to make intracranial bypass between the ventricle and cisternoid space as alternative one to the shunt, so third ventriculostomy was really attractive and applied in the world. This sketch was drawn by Dr. Nakata, a pioneer neurosurgeon in Japan. And here, 3 techniques were proposed. And this was described in 1950s in Japan. And regarding the history, endoscopic procedures are developed after that period, especially 1970s, following Hopkins rod-range system was invented. Thereafter, endoscopic third-ventriculostomy (ETV) became main engine to treat obstructive hydrocephalus, along with anti-siphon device shunt. But new concept about CSF physiology was raised in this century. This is the CSF movement by time slip method. A time spatial labeling inversion pulse technique was applied to tag or label CSF in a region of interest. The tagged CSF was visualized at inversion times after pulse labeling, and you can see that the tagged CSF travels in the aqueduct or between the interpeduncular system and the prepontine system. Those indicate the bulk movement of CSF. So CSF movement is not one-way direction. The brain is a pulsatile organ, and the pulsatility is a feature of intracranial pressure and also a feature of the CSF flow. So, well then, how ETV works in obstructive hydrocephalus? According to the classical bulk flow theory, ETV simply makes a bypass, but it seems intuitive for me. When we change our way of thinking to the modern pulsation theory, ETV acts as a pulsatile absorber and affects distribution of the pulsatile energy from the ventricular space to the subaqueous space by reconnecting the ventricular space with the subaqueous systems. This is a time slip before and after ETV in aqueductal stenosis case. So when you see the images before ETV, you cannot see any CSF movement, but on the post-ETV images, the target CSF travels between the third ventricle and interpeduncular system, and interpeduncular system, the prepontine system, and finally the prepontine system to the spinal canal. These indicate pulsatile movement of CSF. I mean, ETV provides pulsatile pressure buffering in the spinal canal. In addition, the other effect of ETV is to reduce transmantle pulsatile stress. This causes increase in the compliance of the brain surrounding the ventricles. So these are main purposes of ETV from the viewpoint of CSF physiology in current states. I think we are shifting our focus from the potential role of ETV as an internal bypass to understand the changes on intracranial pulsatility and brain compliance. To think about disease entity, the functional classification referred to the circuit model by Professor Rickett is very useful. Here, the obstructive sites are clearly revealed. Among these, intraventricular blockage at the aqueduct and fourth ventricular outlet, that means the foramen lucidum majorly, without the loculation in the ventricle and ventricular breakage at the foramen magnum. So these are considered definitive indication criteria. Now we know these diseases depending on each blocking sites. Unfortunately, I have to skip to talk in details because of the limited time today. I'm sorry. And this is a demonstrable case in these criteria, aqueductal stenosis with pineal region tumor. Currently, the simultaneous ETV and biopsy is sometimes indicated. I prefer to use a flexible scope in this technique because of the way to, I can only go with from the one hole. This is the biopsy, and after that, we completed the ETV. So this good maneuverability of the flexible scope, I can complete the procedure from one hole. And hydrocephalus with fourth ventricular outlet obstruction is also good indication to use flexible scope. From the one hole, we can confirm the obstruction of the lucidum majorly via aqueduct. And after that, back to the third ventricle and complete the ETV. So I think that the ventricular endoscope should be used to treat and also observations to understand pathological conditions. ETV is effective in hydrocephalus patients with long-term shunt setting. Shunt can be removed well, and the patients can convert into shunt independent. Sweet ventricle syndrome is best indication for the breaking away from shunt addiction. And sometimes the ventricles are not open enough to work in sweet ventricle syndrome. So I think navigation or ultrasonography is mandatory for safe insertion of sheath. And the flexible scope with soft tip is better for me regarding the safe manipulation with attaching epidermal surface. This case is Rosal midbrain syndrome characterized by acanthic mutism and Parkinsonism. It is infrequent but profound complication develops in some patients after multiple shunt revisions for shunt failure. And ETV is also effective for this syndrome. This is after ETV. So ETV makes more physiological condition and resolve the symptoms with shunt-free. Okay, this is my case about the long-term outcome of quality of life with the shunt remover with ETV. I tested with the instrumental ADL and EQ5D, and in here, outcome was not dependent on the ventricular size, however, related to the presence of complicated brain damages or the dysplasia. And considering vascular complication, occlusion of the fourth ventricular outlet should be mentioned about, like this case. This is a membranous occlusion of the fourth ventricular outlet, and it causes the enlargement of the fourth ventricle, with pushing the brain stem forward and narrowing the cisternal space of the prepontine and maybe the interpeduncular cistern space. And it is absolutely risk of the basilar artery injury like this. So we should have a brave heart to change the treatment strategy from ETV to shunt in the shape of hydrocephalus, sometimes caused by the fourth ventricular outlet obstruction. Otherwise, we will encounter the catastrophic situation like this arise. Okay. Last topic is management after ETV. Now, some authors refer to optional EVD, maybe previously shunted case, but I myself think basically it is unnecessary. And sometimes transient SIADH or DI are complicated. And so please record urinary output for a couple of days after ETV. And postoperative MRI is essential. I always examine at least 2 images, axial T2 for comparing ventricular size and the cortical side opening to the preoperative one, and T2 sagittal images for detecting the floor void. CSF motion images are attractive, but it is an option, I think. So why postoperative MRI? The long-term efficacy of ETV is reported about the order of 70% in the literature, but we have a risk of the ETV occlusion definitely. According to the literature and our experiences, there are 2 types, the scarring of the orifice with gliosis and the newly formed arachnoid membrane in the cistern. And we investigated an interval from the point of ETV obstruction on MRI as missing floor void and onset of any symptoms. It was ranged from 90 days to 570 days and 120 days in average and 290 in median. So some patients with occlusion of ETV may change into symptomatic, at least for a couple of months after ETV occlusion, not suddenly deteriorate in all cases. And we know that the DETV, the do ETV is effective. And this is a Dutch study in 2017. And many of the audience know this result, and the survival of initial ETV and re-ETV is almost same. And according to these studies, we are able to do re-ETV within a couple of weeks after deteriorate of ETV occlusion on MRI. So I want to summarize my talk as follows. The ETV is alternative to CSF shunt for obstructive hydrocephalus. by means of providing pulsatile pressure buffering in the spinal canal and reducing transmantle pulsatile stress. ETVs indicated, including already shunted patients in obstructive hydrocephalus in current state. And postoperative occlusion of ETV may occur. However, redo ETV is sometimes recommended. And ETV is first choice for treatment of obstructive hydrocephalus in current states. Thank you very much for your attention.
Thank you, Dr. Nichiyama. Questions are going to be done by the end of the session. And please keep up the time of the presentations and 10 minutes. We're having a delay. So I'm asking the next presentators to keep up on 10 minutes exactly, please. And all questions in this session will be done by the end. So, Suresh, you want to go on?
Yes, sure. So our next speaker is Ulrich Thumale. I think we all know him so well. Thumale comes from Germany, and he has got tremendous work in the pediatric hydrocephalus and neuroendoscopy as the management of hydrocephalus. So without wasting much of time, Uli, are you ready?
Yes, I'm ready. Thank you very much.
Yeah. Please go ahead with your presentation.
Okay, thank you very much. It's a great honor for me to talk to you today about neuroendoscopy and post-hemorrhagic hydrocephalus. I hope you can see my screen.
Yes, we can.
Perfect.
Sure.
Thank you. So post-hemorrhagic hydrocephalus is, of course, quite a big challenge for all of us because we don't have only hydrocephalus, but also less or more blood defined by the grading system from Papil. And most of the outcome parameters often mentioned, but not necessarily relevant, is shunt dependency. We have to understand that 9.3% of IVH patients develop hydrocephalus, so not so much. That 38.3% of IVH patients with intraventricular dilatation receive a shunt, and more than 80% of patients who were touched by a neurosurgeon will receive a shunt. So these numbers need to be taken into account when looking at different studies and different techniques. Neonatal IVH means that there's a primary damage due to prematurity first, IVH itself, and the resulting parenchymal damage to this. Secondary damages relate to hydrocephalus and compression of brain parenchyma, as well as treatment complications, which are caused mainly by the neurosurgeons, but also the comorbidities are playing a major role for the outcome. The outcome was nicely investigated by the great Ormond Street group from London, and they showed that the shunt revision-free survival rate is the least in post-hemorrhagic hydrocephalus compared to others, but also the neurocognitive outcome at different age stages from 1 to 5 or 10 years is significantly lower compared to other reasons for hydrocephalus. And this also refers to cerebral palsy, epilepsy, speech delay, schooling, as well as endocrine dysfunction and mortality. One of the big issues are very nice summarized in the Nature paper by the Dutch group, that actually the blood degradation itself, while being degraded in the ventricles, are causing harm by any kind of molecular mechanisms. So it might be relevant to take out the blood as early as possible, but other techniques in order to treat the hydrocephalus is, first of all, ventricular access devices, external ventricular drainages, and ventricular subgaleal shunts, as well as lumbar puncture, according to the recent guidelines from December 2020. In these guidelines, neuroendoscopic lavage was also introduced as being feasible and safe, however, only on the basis of very limited data published in the literature, so it's only level 3, unclear clinical certainty data. We have published neuroendoscopy as lavage technique for IVH patients in 2014 and showed that we can achieve a significant lower amount of shunt rate, down from 100% to 60%, and having a less amount of infection as well as multiloculated hydrocephalus. The time point of putting a shunt was 2 kilograms and lower than 2 grams of CSF proteins, which can be further decreased by neuroendoscopic lavage during shunt implantations as well. How does neuroendoscopic lavage look like? We have one intervention in most of the circumstances in a controlled environment of the operation room to reduce infection and volume balance. We use our endoscope, which is guided by ultrasound towards the ventricle, and then irrigation and passive drainage is started. And then we start to actually take out the blood by aspiration and by irrigation in parallel. We use like 1 to 3 liters per intervention, and the mean operation time is 70 minutes. We can achieve clearance of both lateral ventricles as well as the third ventricle, and thereby reducing a significant amount of blood from the ventricles. The treatment paradigm is normally intraventricular hemorrhage is not an indication, but this in combination with symptomatic hydrocephalus. And then neuroendoscopic lavage will be combined with a ventricular access device. If after intervention further hydrocephalus is relevant, then we actually do punctures to the reservoir, and then we decide if this is necessary on a long-term basis, and then decide for ventricular peritoneal shunt. This is an example that neuroendoscopic lavage is not done too early. So here we have clear blood in 2 ventricles, but we wait over days until the ventricles slowly enlarge. And only if they enlarge, so we can see a dynamic hydrocephalus, then we give the indication to really perform the neuroendoscopic lavage. This is now at the time point here, and you can see here the blood clot and all the blood degrading products accordingly. Indications are intraventricular hemorrhages, of course, elevated head circumference, and clinical signs, however, difficult to interpret due to other problems of the patients. Ventricular dilatations, which are way above the 97th percentile, according to this diagram, and a resistance index, which shows decreased, especially end diastolic perfusion of the brain. Our longer-term results show still a shunt rate of 60%, more or less. And then we could also see that the amount of blood which we're able to take out was that 60% of the ventricles showed less than 10% of blood, and less than 10% of ventricles had after surgery still more than 30% of blood inside. However, this is mostly due to areas which cannot really be reached, like the temporal horn. All ventricles, lateral ventricles, were investigated here separately. Our complications rates were favorable compared to the literature. So we had an infection rate of 3.6%, arrested hydrocephalus rate of 43.5%, a mortality rate of 5.4%, and an operative revision rate of 8.6%. Also, when we look at the necessary surgeries to the shunt, if the patient, in general, with shunt or without shunt, we can still see that the amount of surgeries are lower in mean compared to the patients who did not receive neuroendoscopic lavage. Also, the shunt revision rate, you can see the red curve is now not significantly different compared to other types of hydrocephalus in our cohort. What does other centers say? They say that 60% shunt rate is comparable. This is from the Turkish group as well as from the Spanish group. They have done sometimes more often lavage, which increased their complication rate, but over the time with the learning curve, they had very good results similar to ours as well. The Italian group from Rome did not show a clear reduction of shunt vision rates, and they combined the neuroendoscopic lavage ventricular subgaleal shunts. However, they had significant reduction of infection rate as well as multiloculated hydrocephalus. Here's another paper from Oxford. They showed also a 65% shunt rate, and they showed outcome that 56% of the patients were able to walk and 47% of the patients were either able to attend regular school or regular school with additional support. Our outcome parameters at 2 years were that 78% of the patients were able to walk, and very similar to results that of patients having a good neurocognitive outcome of 45% compared to severely disabled patients, which was similar to the DRIFT study. Further data will be gained by the Trophy Registry, which is an international collaborative effort in order to give more solid data on the basis of our results, but to have that on multiple centers to see what type of interventions are better. I'm often asked, what about ETV? Do you combine ETV with neuroendoscopic lavage? We only have done over a 10-year period 4 ETVs combined with neuroendoscopic lavage. Also, all of them have been done in IVH patients, and all of those patients received a shunt. ETV, however, is, of course, another very important endoscopic therapy, also for IVH hydrocephalus. Professor Constantini already mentioned the age dependency, which was confirmed in the meta-analysis, that age is very important. And in IVH, we have a little bit lower success rates by ETV compared to others. There's a very interesting paper from 2020 from the American nationwide inpatient sample. And they showed over time that they were increasing the performance in post-hemorrhagic hydrocephalus patients of ETV and decreasing the initial treatment by shunt. However, if you look at the failure rates, the ETV failure rate goes higher, while the shunt failure rate remains to be stable, which is, I think, very interesting. Also, you can see that the ETV failure rate is similar throughout the IVH grade, and the mortality rate is higher in ETV patients compared to shunted patients. However, this is very difficult to interpret since the fact that this is only documented data on this nationwide inpatient sample. What about IVH and choroid plexus coagulation with ETV? Only very smallly. Age, again, a very high predictor of failure, as well as is IVH patients. You can see here the survival, the failure curve is the lowest compared to other etiologies. In summary, IVH and hydrocephalus leads to significant, most exaggerated developmental impairment compared to other hydrocephalus types. Shunt revision rates under regular circumstances are high. Neuroendoscopy is a beneficial technique in the treatment of post-hemorrhagic hydrocephalus, and neuroendoscopic lavage specifically is feasible and does effectively decrease intraventricular blood products. Neuroendoscopic lavage may reduce shunt rates and shunt revision rates and enhances the developmental potential for the brain. ETV and ETV-CPC are more directed towards, as additional techniques, towards reduction of shunt rates. And thank you very much for your attention.
Thank you very much, Ulrich. A beautiful presentation. As I said before, questions are going to be by the end of the session. Our next speaker is a very well-known woman in neurosurgery and chair of this session, my dear friend, Nelsie Sanon from Brazil. She will speaking on endoscopy in post-infective hydrocephalus. Nelsie, it's a pleasure to listen to you.
Thank you very much. The mic is open.
Yep.
Are you ready?
Yes, you can go on.
Thank you very much. I'm working in São Paulo. Professor Feres Haddad is the chair of the neurosurgery and recently opened the microanatomy lab. Hope we can receive the foreign people soon after this pandemic time. This speech about infection, hydrocephalus, I will try only to answer these three questions. When is useful neuroendoscopy? Neuroendoscopy is better than standard treatment like external ventricular drainage and antibiotics. And we have less shunt revision or reinfection. Hydrocephalus have a large proportion of our daily work in pediatric neurosurgery and can occur in all age and different etiologies. And this statement is not mine, it's for the RODRK team. The treatment of hydrocephalus remains one of the most difficult challenges faced by the neurosurgeon. It's not technically, but is the decision-making process to choose what the best method of treatment and when. And our colleague Padayashi was happy to publish this last year. We have several options in neuroendoscopic to treat hydrocephalus with infectious disease. Endoscopic third ventriculostomy with or without CPC, septostomy, foraminoplasty, aqueductoplasty, membrane fenestration, catheter placement, or endoscopic lavage. This technique can be used isolate or combined, and we will see that permanent treatment not usually is true for every single patient. It's true for some of them, but not for all patients. And time to time, we need to switch one option to another treatment. It's the reason that we need to be easygoing with every kind of treatment. For example, definitive treatment, ATV, but in some cases we need to redo ATV. The same is VP shunt, but we know time to time we need to revise VP shunt. And when we are talking about infection, we know that ATV failure is linked to previous infections. Or meningitis or ventriculitis, like on this case. The probability of ATV be well succeed without VP shunt is quite rare. We saw already on this morning, if we combine post-infection etiology and young age, we have the probability to ATV not be succeed in the most of the cases. Just one example on these patients is post-tumor with meningitis and ventriculitis. We try to do third ventriculostomy with neuronavigation. We see the anatomy in the infectious patients is difficult. We listened on this morning that the anatomy need to be guide us when we are inside the ventricle. But on this particular case, the anatomy doesn't was clear for us to see where we can perform this stoma. We see this thick ependyma and absolutely not clear anatomy. The guide was essential to end this third ventriculostomy. But at the end of the day, the patient need 2 more VP shunts. And when we combine the coagulation of choroidal plexus with ventricular lavage, we can postpone the ventriculoperitoneal shunt. Maybe our series is very small, sure, but we use only a rigid endoscope to combine this. One of the 3 patients died for this pathology, and 2 others was necessary to put a VP shunt after. In this other case, Diana, it was a very complex neonatal infection. And she's still for 6 years with several different procedures for VP shunt, AVD, and also endoscopy in 3 different moments with 2 years interval, endoscopic septostomy, and also fenestration, aqueductoplasty, again fenestration in the same patients. Just to have an idea, the anatomy on this case wasn't guided. It was before the guidance in the department. And when we are in, if you don't have ultrasound or neuronavigation, you need to guess time to time where you are. We saw some signals of chronic hydrocephalus. We saw some open ostomies, fenestration before. We see the open third ventriculostomy, but still needing a VP. And she was alive for 6 years, and the mom became a nurse afterwards. Our last patient is quite recent. It was a myelomeniingocele patient, postnatal closure, and it became with tense fontanelle, irritability, abdominal distension with no pseudocyst, and instability, clinical instability. The recent surgery, it was myelomeniingocele repair, VP shunt, and a shunt revision before. And we saw the integrity of the VP shunt system, the dilatation still there. And we perform a ventricular tap with normal CSF, normal ultrasound, but the general pediatric surgeon evaluation of with distension abdominal discomfort and pain, we externalized the shunt, and after some days we found a ventriculitis, and we perform a shunt removal, AVD, and antibiotics treatment. After 10 days, it wasn't better. The question was fungal infection, bacterial, or something different. We just decided to do a brain ventricular lavage on this case. We saw at the beginning it was like a cotton inside. We saw this image usually in the fungal infection, not more common in bacterial infection, but can be combined like on this case. And at the beginning, we tried to aspirate. We saw the ventricular catheter inside the ventricle, and we look around and try to aspirate with the Fogarty, just the tip cut. And with the serang aspiration, it wasn't efficacious. The efficacy was so slow, and probably we stayed there for some hours. We just decide to connect the aspirate at the end, and we just goes faster with this technique. And it was with our resident Isaac that do this editing video. And we saw at the end of the surgical procedure better ependyma and better anatomy. Is not absolutely clear, but sure is much better than at the beginning of the surgical procedure. On this case, we saw the choroidal plexus, but wasn't in our plans to do the choroidal plexus coagulation or endoscopic third ventriculostomy. We became in the same discussion. I agree with Shlomi. Is a small baby with post-infection meningitis. Is better try to solve the case with a VP shunt after the infection. And if they need shunt revision at the end, we think about endoscopic third ventriculostomy. And here we saw the new ventricular catheter put inside. It was so beautiful anatomy, and we try to close the AVD and remove AVD, not VP shunt indicate at the end, but we saw CSF fistula, ventricular enlargement, and the treatment was necessary to do VP shunt again. And we saw already these papers from Tomali. they answer the question. The neuroendoscopic lavage result in decreasing number of shunt revision and shunt dependent patients. And the answer for our initial question, when is useful hydrocephalus and ventricular infection, better than standard treatment or less infection and reinfection. The preliminary results is yes, but we need more cases. And our policy to treat hydrocephalus with infection is first treatment, external ventricular drainage and antibiotics. And if we need a change of AVD or reinfection, we add ventricular lavage. And the message is guideline is important, but it is important also individualized treatment and be ready for a neuroendoscopic procedures and can help. And hope we can meet each other in Bogota next March. Thanks for your kind attention.
Rish, would you like to
thank
go
you,
on?
Nels. Yeah, sure. Thank you, Nelsie, for this beautiful presentation. And now it is my great pleasure to invite and introduce one of my colleagues from India, Dr. Subodh Raju. He is a very active pediatric neurosurgeon and endoscopic neurosurgeon, and is presently the secretary of the Neuroendoscopy Society of India. So Subodh, will you please share your screen? We would like to hear your presentation. Subodh, please.
Yeah, a very good evening. Hope you can see my screen.
Yes, we can.
Yeah,
go ahead.
I thank the Neuroendoscopy Committee for giving this opportunity. And my topic is, again, sequelae of hydrocephalus or multiseparate hydrocephalus. And a challenging thing to treat. A number of names have been given to this hydrocephalus, starting from multiloculated to multiseptate to polycystic brain disease and other things. And is defined as a multiple separate cystic cavities or spaces located in or in relation to the ventricular system and filled with fresh or altered CSF. That's a basic definition of a multiseparate hydrocephalus. Usually, it's a complicated form of hydrocephalus following an intracranial infection or an hemorrhage. And the normal ventricular anatomy is totally disrupted. And multiloculated hydrocephalus has been defined as a progressive disease. So for me, it's a progressive disease or it's a dynamic disease, always. So what are the issues in hand in multiloculated hydrocephalus? These are the children, infants and kids with severe disability who present with raised ICP. And rationale of any treatment should be treating an infection. There's no infection, decreasing the intracranial hypertension. No particular standard treatment or this thing is suffice for thing and may require multiple shuntings in the initial days. But with the advent of endoscopy, we know this. So loculated ventricles can be uniloculated or multiloculated. And today I'll be basically covering the multiloculated or the multiseparate hydrocephalus. The uniloculated hydrocephalus can be congenital, but multiloculated hydrocephalus generally post-infectious or post-inflammatory. So these are formed because of a pseudosepta formation, and you're not true septas which are formed between the ventricles, and they are basically fibrous adhesions, and it can be because of an infection causing an ependymal injury, a glial protrusion, or formation of ventricular membranes. Initially, these membranes are flimsy in nature, but gradually over a period of time, they become more and more organized. How do you diagnose them? Simple thing is a frontal is open, an ultrasound, CT scan, MRI, or a CT ventriculography. What are the management options of this? Shunting, stereotactic aspiration, craniotomy in complicated cases, and endoscopic fenestration. And the combination of all these things, endoscopy plus shunting, actually. Craniotomy is very rarely done, but it's done in cases of very, very thick membranes and these things where you cannot put a shunt or endoscopy cannot be done. And popularly, we nowadays use this endoscopy plus shunting. The initial days, multiple shunts. We have seen old scans with carrying 5 or 6 shunts, and more number of hardwares, more chances of infection, and more chances of shunt revision in these cases. Shunting alone is always unsuccessful, and scarring and collapse of the cyst can lead to shunt blockage, and it can lead to intraventricular hemorrhage because we are dealing with inflammatory ependyma. So we have to be careful when doing a blind shunt procedures in these cases of multiseptate hydrocephalus. This is a simple example. 6-month-old child with a post-meningitis, post-ventriculitis, presented increased size. Ventricles, if you can see here, they are multiloculated, multiseptated, and it's a progressive disease because you can see this encephalomalacia which is forming. So what is the aim of treatment is to communicate all the loculations into a single cavity and place a single ventricular catheter. So we did multiple, through a single burr hole using a rigid and a flexible endoscopy, multiple septations are done. These are on inflammatory septations, so you have to remember that whenever you do septations, they should be decently large in size. The small septations will usually close in nature. The multiple shunt placement was a classical in the initial ways of treatment, but we know it has not been successful over a period of time. Now comes the use of endoscopy, neuroendoscopy. There are challenges because the cerebrospinal fluid loss with the introduction of endoscopic cavity, the anatomical points, even if you're using the navigation, the anatomical points can change. So we use combining navigation and intraoperative imaging. It could be an ultrasound if the frontal is open or a navigation. Repeat endoscopy procedures is required if it is not successful in the first time. So there's a child, one case, 4 months, meningitis ventriculitis with hydrocephalus, resolved, treated with antibiotics, presented after 3 months with raised ICP. So you can see here, there's a large loculated hydrocephalus, and the already EBD and the shunt is there already in place. This is the coronal view. You can see the number of cavities which are there. This is the SAG view. So what we did was an endoscopic, navigation-guided endoscopic surgery, where we fenestrated number of septations, and after fenestrating these septations, sorry, media is unavailable. After the fenestrating these septations, then a single shunt is placed. And a navigation-guided shunt placement is also done at the end of the procedure. So what happened after 4 months? This thing was, after you place the point, as I told you, it is a dynamic disease. New septations formed, and new septations formed after 4 months, and the child again presented the hydrocephalus. The initial shunt which we had placed here is lying at one side. The cyst or the cavity in the septate cavity in which the shunt was placed is completely pushed, and new cavities have formed in this, because it's an ongoing process in many cases actually. You can see here. So what we do is, in these cases, a small nuance in doing a navigation-guided surgery is, we do the endoscopy exactly from the opposite side where the shunt is there, and try to communicate each septation till we reach the shunt here. So we pass the through under navigation guidance, we pass the endoscope, keep on doing septostomies. So we enter from here, do septostomy, septostomy, septostomy till we reach the shunt here. So you can see, after removing 1 by 1 septations, you can reach the shunt there. And then the shunt is pulled and placed inside in this cavity. The all smaller cavities are also opened up in these cases. This case you can see here, navigation guide septostomy. The shunt is placed and pulled inside this. Similar other case, you can see after you pierce 1 by 1 membrane till you go there, and the shunt is pulled to this side of the. So as you have communicated all the cavities, and one single shunt is sufficient for that. So we plan and calculate the longest trajectory where we can cover in maximum number of these cavities actually. Similarly, another case, same way we do it. This is another case of a post-infective hydrocephalus with multiple septations. In this case, also the same septostomies. Multiple septostomies are done one by one. Coagulated, and then again, if the shunt is already there, search for the shunt and try to pull it into the same cavity. So we are after opening it and going into the shunt is functioning well actually. The shunt is not blocked. Only the cavity had collapsed. That's why the shunt was not functioning. So we pull the shunt into from one end to the other end. So the communication is there and the shunt has been placed in this case. Similar cases of same. This one has an ependymal enhancement. So it's an active ventriculitis. In these cases, we do a ventricular-subgaleal shunt and the septations are forming. One important thing is, why do we do a lavage? Every month we try to do these things lavage to prevent these adhesions which we have. Interventricular antibiotics, IV antibiotics plus lavage is done to prevent these adhesions, flimsy adhesions. This is a post-infarct multiseparated hydrocephalus with mass effect. So differential CSF analysis. In multilocular hydrocephalus, CSF cell count and biochemistry can vary in different cavity. If one of the CSF samples given evidence of infection, the infected shunt system should be removed and replaced with an external ventricular drainage and an appropriate antibiotic. So if you're getting a normal CSF in one of these cavity but infected in another, the management has to be tailor-made according to that way actually. Like in this case, so in one side, it is a clear thing, enlarged ventricles, this managed with ventricular peritoneal shunt, where the other side was an infective one, so we put a ventricular subgaleal shunt in the other side. We didn't try to communicate these two things actually. So in these post-infective cases, an EVD or a ventricular subgaleal shunt has been shown to be very effective. So recently in our Neurology India, we had a very good supplement on hydrocephalus, and we had this article published on management of complex hydrocephalus. It got published recently, last month only. Our experience, we have around 64 cases of these things which have been treated with flexible and rigid endoscopy. All methods and all combinations have been tried, including endoscopy, shunts, re-exploration, re-shunting, and I told you no single procedure suits a single patient according to the requirement, and these things it has to be tailored actually. So concluding, infection is a major cause of development of these multiseparated hydrocephalus. Establishments of a communication between trapped ventricles and ventricular system is key in management of trapped ventricles, and managing complex hydrocephalus requires a multimodality approach. Endoscopy achieves communication in a minimally invasive way, and when satisfactory communication cannot be established, an external EVD or a shunt has to be placed. If you have a neuronavigation and an intraoperative ultrasound, it is very helpful in guiding you in your surgery. And it remains a difficult problem in the practice of neurosurgery, and neuroendoscopy surgery can be considered a valid alternative to traditional multiple shunts in placement of these catheters and avoiding a craniotomy on any major surgical procedure. Thank you very much.
Thank you. Thank you very much, Dr. Raju. Our last presenters, and to end this session, is going to be Dr. Qureshi, from Kenya. And he will be talking about nuanced thinking in complex hydrocephalus. Dr. Qureshi, are you already with your presentation?
I am, but I'm having some difficulty sharing at the moment. I'll be with you in a moment.
Oh, okay. Meanwhile, if there is any questions on the last presentation, we can use this time. Unless you are ready, Mahomet. Not yet?
I think it's coming out. Let me just check now. Yeah.
Okay. There you go. Perfect. You can start.
All right. I've already thanked you now. Let me just go. Right. Let me just go straight. I'm having difficulty.
Yeah, no problem.
In a moment.
Get the first one.
Thank you. Right. First of all, I'd like to thank Nelsie for inviting the Neuroendoscopy Committee to provide a joint symposium. I think it's just appropriate and timely, considering that both our terms have come to an end and we really need to get all our team members an opportunity to present. I have brought this up because of the challenges that we face, just like many in the LMIC countries in sub-Saharan Africa. Wherever you go, you have mothers collating around you, hoping that their child can be treated. And those children have all sorts of problems, mental retardation, delayed milestones, shunt infections. And
excuse me, doctor. Can you place your full screen on it, because we're seeing your
okay,
computer.
all right.
There you go.
No, it's not showing on mine.
Just click the slideshow button.
Yeah, slideshow, I think. Woody? Yes.
Slideshow, not this one. This is a presenter's view. Go for the slideshow.
Slideshow, right. That's the one.
Yeah, yeah.
Down below?
Yes, here is the slideshow.
Right hand, left hand corner down. Yeah. The next button, next. Besides that. Yeah, that one.
Yeah. That one. Slideshow.
Pressing that, but then that brings me to this.
This one.
It brings me to that one.
So you have a default presenter's view setting then.
You should go to swap displays on the top.
There we go. Is that better?
Still not
perfect.
The full view.
On my screen, I'm seeing I'm seeing a single view, but
okay. I think it should be all right. Woody, go ahead, please.
I think we'll just have to live with that because that's the setting. The other problem we have in our setting is the various anomalies that we end up seeing, and that becomes a major problem to manage in our setting. So we conducted this study in our hospitals, and essentially just to see what kind of anomalies that we have, and we found that the norm was actually anomalies. Very few patients had normal ventricular anatomy. Of the cases that we saw, just a fifth had normal anatomy, 4/5 had abnormal variant anatomy. And the implication of this is that the variant findings were associated with a longer procedure time for ETVs, and when we did it equated to normal ventricular findings equated to shorter procedure times. As a result of this, we went ahead to propose a African Federation of Neurosurgical Society grading, which grades from 1 to 4. We're still evaluating it, and we hope that this will emerge into a study which is multi-center, so that we can see whether this is a valuable grading. The gradings that we have is grade 1, 2, 3, 4, and 5, and where this has been a result of infection, where the anatomy is normal, we grade it as A. Where the anatomy is abnormal, we grade it as B. And essentially, grade 1A would look, as we've seen in many of our images that have been shown, the anatomy looks absolutely clear and the ventricular wall is pristine. When you go to 1B, the ventricular wall is pristine, yet we have various variants of the anatomy. So that becomes 1B. In 2A, we have signs of early infection with hemosiderin deposits, hemorrhagic changes in the ventricular wall, but the anatomy is normal. On 2B, the anatomy is abnormal associated with those findings. We go on to grade 3, where there are thick fibrous strands, as we've just been seen by Raju just now. And this is grade 4B, where when you're looking at it, it looks like a leopard skin appearance. Now, and then grade 5 is what, again, has been shown in the multiloculated images. Essentially, what this relates to is when we look at this, the time taken to do endoscopic third ventriculostomy and its success seems to be related to the grade of this patient. If it's a 1A, the child is, according to the ETV success score, appropriate, you're more likely to succeed. As you go down the grades, ETV is going to fail. And in the multiseptate or multiloculated grade 5s, even shunts are likely to fail, as has been shown by Raju. So, therefore, as in all surgical undertakings, a clear understanding of what the anatomical variation is, what the pathology is important, and the ventricular anatomy is being prone to variations, will result in the success or failure of your treatment. So this is a case to illustrate a 3-year-old child who presented with hydrocephalus and delayed milestones to a primary neurosurgical team who initially diagnosed this as a Dandy-Walker malformation. And as you will see, this is what they considered to be a Dandy-Walker malformation. And when you look at it, the question was, do we shunt or what do we do with this patient? They decided they decided to shunt. Of course, shunts in this situation resulted in complications. There was a bowel perforation with distal catheter coming out through the anus. The distal catheter was replaced. A proximal catheter was left in situ. Meningitis, ventriculitis happened. A second proximal suboccipital catheter was placed into the suspected so-called Dandy-Walker cyst. There was a short-lived improvement, possibly related to a reduction in intracranial pressure, but then gradual deterioration. They then went ahead to refer to 3 different teams in the city, seeking their assistance in doing a third ventriculostomy. Didn't seem an appropriate thing to do, because when you look at the anatomy and let that be your guide, you notice that there is something that is not going to suit what was originally planned, the shunt or an ETV. So here is the pathology. This is actually a large posterior fossa arachnoid cyst, which is then pushing against the third ventricle and pushing this, causing the hydrocephalus, compressing the aqueduct against and closing it off and pressing the cerebellum right down. So now, faced with that situation, you really don't want to carry out an ETV because of the likelihood of the circle of unhappiness, as we all have come to learn. So when you look at this, the original shunting that was done, you realize the shunt is just not actually adequately placed. Ideally, it should be in that sort of situation. When you look at the second cystoperitoneal shunt that they had placed, again, it was inadequate in its placement. And then the question is, how do we go about it? This is where now you need to let anatomy and the pathology itself guide your decision making. We decided in this sort of situation, a microsurgical cyst fenestration of the third ventricle would be the more appropriate way to go. And this is just a brief outline of how this was done. For purposes of time, so now we're in the cyst. We're looking at the structures within the cyst, and now we are able to see the vein of Galen, the veins of Rosenthal, the anterior cerebral veins, and the third ventricle and the pineal gland, and essentially gives you an opportunity to microsurgically create a cyst fenestration. That's your vein of Galen, the basal veins of Rosenthal, and the internal cerebral veins. And you are now in a position, once you've identified the anatomy, in a position to create your fenestration microsurgically. And that is what was done in this situation. As you will see, as you go through, you dissect, and you're able then to get an egress of CSF. You're into the third ventricle. You then widen your opening sufficiently. And in this sort of situation, there you see the inside of the third ventricle, and you are then able to actually determine the size of your fenestration. And in this situation, it was just over 11 millimeters, which is shown here. And you've got a good view of your third ventricle after doing the fenestration, and a good sized fenestration. So essentially, this is what the situation was preoperatively. This was now on day 5. You can see the cysts smaller. You can see the path the CSF is taking, and you've opened up the aqueduct into the fourth ventricle, and the cerebellum is beginning to operate. And this is the young girl, third day post-operatively. And on 14th day, you see significant improvement in the cerebellum and significant improvement in the child. So what is the learning point here is that there is importance in collaborating when you are discussing, when you are met with complex cases. One should always discuss what the underlying etiology is before planning management. Have an open discussion with different team members over the modes of management. A detailed evaluation of the radiological anatomy by the surgeon himself, not just looking at the report, and then a thorough knowledge of both endoscopic and microsurgical anatomy. This then leads you to treat the patient in the most appropriate manner. Thank you very much.
Thank you very much, Dr. Korechi. Very, very nice presentation. Can you get out of the screen, please?
Yeah.
So we open up the discussion Suresh, if you agree, of all the subjects that are being treated, we have some time for questions and discussions on the different issues.
Sure.
Is there
Let us
anyone
start.
that would like to take the word?
Yes, I think let us start with a few questions. And let me start, Uli, with you. What is your current practice in the ventricular lavage? Do you really do simple ventricular lavage, or do you do ETV and plexotomy simultaneously? And do you use the flexible endoscope or the rigid endoscope?
Yeah, thank you very much. Very good questions. So we have a very strict protocol, and we use only ventricular lavage plus clot aspiration. We normally don't do ETV because we think that most in the cases ETV will not successful. Maybe it might postpone hydrocephalus a little bit, but it will not be in long term successful in preterm babies when you do the ETV so early. So we have done it only very few cases. We don't do choroid plexus coagulation. We actually use a rigid endoscope because a flexible endoscope has only one channel, and it's very hard to really do irrigation with only one channel because you need at least two channels, irrigation going in and the other one irrigation going out. So this is what we do.
Right. Thank you. Thank you very much. Any other question?
Ulrich, I have a question for you too. You mentioned that sometimes you use the aspirator to get the clots off. Considering that you are treating very small children, under 2 kilograms of weight and probably just born, aren't you afraid of taking some brain tissue out with the aspirator?
Yeah,
because sometimes the blood is very sticking with the white matter, and there's not yet an ultrasonic aspirator for endoscopy that you can trust of having just very, very mild aspiration. So I also use the normal aspirator with regulating with your finger, but sometimes it can be dangerous. What do you think about?
Yeah, no, I absolutely agree with you. We don't use the aspirator because we think it would be much too dangerous. What we do is we put a tubing at the outflow channel, and we connect intermittently a 5 or 10 cc syringe. And with this syringe, you can gently aspirate by 2 or 3 milliliters if your endoscope goes very close with the outflow channel to the clot. And the very positive thing about clots in neonates is that they are soft and it's easy to aspirate them like this, which you cannot do in older children, for example. And according to the fact that the risk of like stickiness of the clot to the tissue, it's actually, if it's not an intraparenchymal bleeding, it's not sticky to the ependyma. It's only sticky to the choroid plexus, and this causes sometimes some bleeding, but this can be controlled by either irrigation or by coagulation.
Coagulation. Okay. Okay. Thank you.
You're welcome. Thank you.
Any other questions for Ulrich? If not, then the next speaker was Kenichi. Kenny, any question or comment for Kenichi?
Oh, well, he spoke about redoing third in some cases. I wonder what are his factors to decide when or when not to do redo.
Your comments, Kenichi.
Yeah. Can you hear me? Basically, yes. I do the redo ETB at first. And next to my choice is the redo ETB with stenting. You know, the stenting with a tube stent or so. And so anyway, I want to avoid the shunt for the child, especially for a child. And maybe the first redo ETB and next redo ETB with the stent, and finally I use the shunt. So I like ETB.
Okay, thank you. Thank you. We move on to Nancy. Nancy, just one quick question for you. What is the best time of doing the lavage in ventriculitis? When would you consider ventriculitis during the course of the treatment? Are you there, Nancy?
Okay. Thank you for your question, Suresh. We don't start doing ventricular lavage just at the end of the diagnosis. We start doing the diagnosis or with ventricular tap or with the AVD, the external ventricular drainage. And we try to treat. We have 2 or 3 samples during the week. If something doesn't improve during these days, we think about the subject and we think about going and doing lavage. In the second option, not first option for treatment at the moment. I don't know if someone of you start ventricular lavage just at the diagnosis or of ventriculitis, just at the beginning, because we may have some complications also. We start with less invasive, just IVD, quick, and try to see.
Perfectly. All right. Thank you, Nancy.
Thank you.
Nelsie is telling me that we are 30 minutes late. So I'm afraid that we have to finish this session. Sorry, but everybody is taking more than the 10 minutes. So we'll be ending this session, and I would like to thank everybody, and especially the speakers. It's been a wonderful session, and I think everybody has learned a lot on complications, on all these difficult techniques, because we're not speaking on normal ETV. Always, these cases are the most complexes for pediatric neurosurgeons. So congratulations to everybody. And Suresh, was a pleasure to share with you. And you have the word.
Thank you very much. Thank you very much. And I think with these words, we just conclude this session and move on to the next one. Nancy?
Thank you, Suresh. Pujari, would you like to introduce the last topic?
I think for our next session, Martin is not here, but I can see Dr. Okal is here with us, and Dr. Venkat is with her, right?
Yeah. Yes.
To chair this session. So Dr. Venkat is a friend, neurosurgeon in Bangalore, and he is director of the Brain Institute over there. And Dr. Elim Okal is now recently working in. Can you just let us know your current designation? I have forgotten. Is it Arkansas?
Arkansas, yes, sir.
Right. So she is from Arkansas, and both are well-known pediatric neurosurgeons. I'm sure you all know them, and I request them to start the new session on arachnoid cysts. As you know, we are running short of time. We tried to cover too much. I think that was our probably fault. We had to probably do 2 sessions rather than 1. But now that we are here, let us do the most of it. Please start the session.
Thank you, Nelsie and Dr. Pujari, for this opportunity. Without much ado, we'll move on to the first topic, middle fossa arachnoid cysts by Arthur Dicona. He's a well-known pediatric and the endoscopic surgeon from Brazil. Arthur?
All right.
Yeah, please go ahead. Yes.
Fantastic. Okay. Thank you, Pujari and Nelsie, for the nice invitation to this online meeting. And arachnoid cysts are not a very common occurrence, especially since most are asymptomatic and diagnosis usually incidental. Most of these cysts remain indolent, but some may expand or even rarely rupture and cause symptoms. The topic involves many controversies regarding surgical indication and the choice of surgical procedure. Of course, the time is too short to discuss in depth a topic with so many variations and controversies. So, arachnoid cysts are benign congenital developmental anomaly occurring between layers of the arachnoid membrane extraaxial fluid filled similar or equal to CSF. Represents 1 to 2% of expansive intracranial lesions. The arachnoid cysts present a prevalence of up to 2.6% in children. They are usually asymptomatic and the diagnosis is very often incidentally. The natural history of and pathophysiology are not well known. Spontaneous resolution or progressive enlargement has been described in the international literature. Almost half of the arachnoid cysts are located in the middle fossa, as you can see in this chart. We'll find several ways to classify arachnoid cysts of the middle cranial fossa. The most mentioned classification model is the one proposed by Galassi in 1982 based on imaging characteristics. So we have the type 1, is a small lenticular biconvex located anterior pole of the middle fossa, apparent free communication with adjacent cistern. Normally, they don't have mass effect, normally no cranial change, often incidental findings, no indication for surgery, and represent about 20%. The type 2 is something bigger than the type 1. Had triangular or square shape. The communication with the basal cistern is less common. These type 2 cysts are more likely to require surgical treatment and represent about 50% of the case. The type 3 is bigger and rounded, more often symptomatic, enclose the entire length of Sylvius fissure, show mass effect and the midline deviation, cause bone change like temporal bulge, temporal bone thinning, normally no communication with adjacent cisterns, often require surgical treatment and represent about 30% of the middle fossa arachnoid cyst. Clinical presentations, we have there, as I mentioned before, most arachnoid cysts of the middle fossa are asymptomatic. And we can imagine that they are never diagnosed. Some cases have been diagnosed by necropsy and other through imaging exams like tomography or magnetic resonance imaging carried out to investigate other pathology. The observation of cranial deformities such as bulge or asymmetry can lead to image investigations and diagnosis of this cyst. In symptomatic cases, cranial deformities may or may not be present and are associated with headache, seizures, neurological deficits, and developmental and behavioral disturbance. Signs of intracranial hypertension may be due to the presence of hydrocephalus, which reveals an important disturbance in the CSF circulation. The first big controversy is how to treat asymptomatic cyst. As most findings are incidental, in our experience, it's common for the diagnosis to be made in older children with stabilization of the lesion concerning progression. These patients also, even under monitoring, in most cases do not present clinical or radiological signs of intracranial hypertension. Sorry, someone has the microphone open. Okay, then, as I said, some have a history of seizures, but there is no strong evidence that the surgical approach to the cyst will eliminate the epilepsy focus. Another argument for indicating prophylactic surgery is the possibility of post-traumatic bleeding associated with the presence of large cysts. The occurrence of spontaneous or traumatic bleeding is not very common, and the risk appears to be similar to the risk of surgical complication. In case diagnosed in the first 2 to 4 years of life, we recommend outpatient follow-up and surgical intervention only in case of progression of the lesion, of course, or onset of symptoms. We do not recommend the indication of prophylactic surgery. So, cystoperitoneal shunt or ventricular cystoperitoneal variant remains the most frequent option in the treatment of arachnoid cyst of the middle fossa. Perhaps because it's a simple procedure, not very invasive, and does not require technological tools. The problem with shunt is the long-term complication. The open approach of middle fossa cyst with the aid of microscopy is a good alternative in opening the membranes and communicating the cyst with the basal cistern. It requires a prior and detailed study of the anatomy. The procedure is very invasive and consequently with important risks to be considered. Consider the minimal invasive characteristic and to avoid the long-term complication observed by shunt implantations, endoscopic surgical fenestration has become the primary approach. A combined approach of microsurgery and neuroendoscopy, this is so-called endoscope-assisted fenestration, can greatly improve outcomes. So there is no specific protocol for approaching arachnoid cyst of the middle fossa. The type of cyst, the age of the patient, the findings of the imaging exams, the presence or not of hydrocephalus, and the research available in each pediatric neurosurgery department are the factors that define the type of approach to be performed. Again, about the cystoperitoneal shunts, are still the most frequent options in the treatment of arachnoid cyst of the middle fossa. The use of adjustable valves can be an important resource in the prophylaxis of subdural collection. In our little experience with the surgical treatment of arachnoid cyst, we observed that the implantation of shunts is more effective in the volumetric reduction of the cyst. A cystoperitoneal shunt may also be the second option in case of failure of open or endoscopic fenestration. And in the presence of associated hydrocephalus, we can perform a third ventricular cystostomy and the endoscopic fenestration and then implant a shunt. So we can communicate all CSF space. The second most frequent approach in the treatment of arachnoid cyst of the middle fossa is the microsurgical fenestration with and without marsupialization through a craniotomy. The use of neuronavigation is recommended to make the procedure more secure, guiding the opening of the membrane to the basal cistern and avoid damage to neuronal structure not visualized positioned just behind the membranes. There are many controversies about the need for marsupialization, especially because of the high risk of hemorrhage and neuronal lesions. We can also associate the use of neuroendoscopy to broaden the surgical field of vision. One of the most used arguments in the indication of fenestration in the cystic wall is to allow a broad communication between cystic and cysternal space, and of course, to avoid the implantation of shunts and its well-known complication. However, in addition to the complication observed in open fenestration, failure of the procedure is observed in around 20 to 40% of cases. Endoscopic fenestration is an effective and minimally invasive approach as the first option for treating middle fossa arachnoid cysts, especially in the Galaxy type 3 cases. Improvements in neuroendoscopic equipment and technique have improved the surgical approach to this cyst. As with open surgery, the purpose of the endoscopic approach is to open the membrane as wide as possible and establish a communication between the cyst and the basal cistern. The neuroendoscopic approach is less invasive and has fewer complications in experienced hands. The use of neuronavigation is essential in this endoscopic procedure. Unfortunately, the endoscopic approach also showed about 20 to 30% of failure. And we have complications. Then you can see here the common complication by cystoperitoneal shunt, of course, infection, malfunction, overdrainage, hemorrhage, subdural collection, open fenestration, hemiparesis, cranial nerve pulse, vessels, injury, infection, increased seizure frequency, postoperative hematoma, subdural hygromas, and CSF leaks, and the endoscopic fenestration you see here, the minor bleeding, infection, subdural collection, aborted the procedure due to technical, anatomical, or bleeding difficult, and also very common is the CSF leak. To conclusion, regardless of the type of cyst and the clinical presentation, there is still no consensus regarding the treatment. There are still many doubts regarding the surgical indication, and there are many contraindications. There is no proof of the benefits of prophylactic treatment. The primary endoscopic approach may be an option in the treatment of some type 2 and type 3 cysts. The surgeon's knowledge and experience are important factors in preventing complications. So thank you very much.
Thank you, Arthur, for a very lucid presentation. So
thank you so much, Dr. Junha. This was a great review. We are a little bit late, so we'll get the discussions at the very end. However, I want to mention that I think our audience is not complaining about the length of the discussions because we had more than 300 live participants plus the more than 100 in YouTube. So we're going to continue with suprasellular cyst. Professor De Rocco from France is here. I don't think there's any need for introduction. Let's go ahead then. Thank you so much.
Thank you very much. It's really a pleasure for being here. So I would like to thank you all for this opportunity and congratulate Professor De Pujar and Professor Zenon for the organization of such nice webinar. So I try to share my screen. I hope you can see it. Please confirm that you do. Is it okay?
Yes, we got it.
Perfect. So The topic was the supercellular cyst. So I would like to thank Professor D'Acunha because he's already introduced a lot of the talk. So we are going to go directly on the supracellular region. And of course, these are some typical characteristics of the cyst, which are quite rare because they represent only a minority of the cysts. They are considered to be some 9 to 20% of all the cysts. There is Mickey Mouse because this is the typical Mickey Mouse appearance of the cyst, but probably their incidence is still lower. You see here in a recent study on 100 of children with cyst, only 3 were in the supracellular region. So you see that probably the incidence is quite low. What are the symptoms that bring to the diagnosis? Of course, they are related to the region we are talking about. So there will be problem of endocrine, but there can also be epilepsy, which is quite surprising for this type of location. And of course, there is the mass effect leading to hydrocephalus, macrocrania, ophthalmological problems, and in children, young children, developmental delay. So you see that this lesion can be quite large at the time of the diagnosis, and the symptoms and signs will differ according to the age group we are dealing with. There is an age effect. Symptoms of macrocrania motor deficits are those that lead to the diagnosis in a very young one, like the gaze disturbances, and lately you will have more visual or endocrine problem that will lead to the diagnosis. And you see this in a review that the same group did on 200 cases. Again, there were differences in the incidence of the different symptoms and signs according to age. Supracellular cysts can be classified according to the type of location from the anatomical point of view, with interpeduncular and prepontine cyst, which have a slight different anatomical characteristic. The interpeduncular one are from the liquids membrane. The prepontine one are more arachnoid related cysts. The interpeduncular one can still be, in some cases, arachnoid cyst. Either one are interpeduncular cyst enlargement. But this anatomical classification, which is not really important, as the same author said, for the surgeon and from the practical point of view. You see here, those are some examples of what we're talking about. Some cysts can be more interpeduncular, some can be more prepontine, but at the end, when they enlarge, they will end up leading to similar characteristic from the radiological and from the surgical point of view, with the basilar, which will push forward. What is important is that we consider here the supracellular extension. You see here that the limit of the cyst would be rather high in the prepontine one, and below the low part will be very low. This is important we will talk about that for the surgical point of view. So these are some examples of the cysts, and you see that it's sometimes difficult to define exactly where they are. But what we will not talk about is those who are really prepontine. What is important for the surgeon is to distinguish those who develop in this region, because some of the cases will go very high and lead to an hydrocephalus, and some will not. So there are different type of radiological extension. So we can have a radiological classification distinguishing those with ventricular dilation, those without ventricular dilation, and those extending the temporal region. These are some examples. You see here that there is a dilation that goes high in the third with the typical Mickey Mouse and the dilation of the ventricles. Those who remains really in the supracellular region without dilatation, and those will extend also laterally. This also probably is related from the anatomical point of view, as you have seen at the beginning, to relationship with the floor and the arachnoid walls. Why it is important to distinguish those? Because from the natural point of view, the natural history point of view, they will do different. They behave differently. The type 2, those without hydrocephalus, sometimes will remain, will not change in time and in size, and those type 1 and 3 with the hydrocephalus, with the lateral extension, generally during time they will enlarge. Most of the type 2 are able to be stable. Those type 1 and 3 tend to increase. Only rarely they remain stable or regress, and they will become symptomatic. So we know that they can increase, they can lead to the hydrocephalus, the macrocrania we talk about, the mass effect, but will respond to surgery. Type 2, they can remain stable. There are several cases of antenatal cysts that remain stable those of type 2. Some of them may also regress. So we have these reports from several studies here and another one that showing that this type 2 can tend to regress during time, and follow-up still is mandatory because not all of them, of course, will regress. You see here an example of increase. When the increase is type 2, they can be quite large and again give different signs as we have seen. Some of them are due to the mass effect, they will respond to surgery. Others are probably more a malformative issue with endocrine dysfunction, with the problem of the puberty, so more endocrine, and those will not respond completely to the surgery. Those problems can persist. So this is an algorithm we can use, starting from this radiological classification. Type 1, type 3, we know that they will increase. There is a mass effect leading to the diagnosis. Surgery is the solution. Type 2, sometimes they can be asymptomatic, so there wait and see. If there are symptoms and they're related to mass effect, the surgery is considered. If they are just endocrine problems, sometimes the surgery will not solve the problem. So what is the surgery we're talking about? In the past, there was a direct approach. These are all the scan, and you see the problem of the dilatation. And of course, you would do a direct transventricular approach to the cyst and fenestrate it. Nowadays, of course, we move to the endoscopy. We want to restore the CSF flow. We saw all the discussion about the flow with Professor Nishiyama presentation. So we want to restore this bulk flow, and we want to do a ventricular cystostomy to reduce the size of the cyst, the mass effect, and access from the ventricle to the cyst. But of course, we want also to open and do as when we can the cystocystonostomy. But again, as I show you, it will depend where the lower part is if there is no prepontine extension. And we want to open the lower part and do a ventricular cystocystonostomy. And you will see here, in most of the cases, also the entrance of the valve mechanism that will allow you the cyst to increase in size. So what we want to do, puncture the ventricle, puncture the cyst, and do a ventricular cystocernostomy. At the end, this is a quick example. We go fast for this. You see the cyst in the ventricle. Then we will puncture. We will enter the cyst, and we will see the inner part. You see here the inner part of the cyst. It's always a very beautiful anatomy of the Willis of the epiphyseal region, clivus, and you want to do another stoma at the end. Of course, we are very low, so it's a complex procedure. You don't want to damage the neural structure, the vascular structure, so you need to know where your flow will be. So what to do, a ventricular cystocernostomy or just a ventricular cystostomy? Well, we know that the results are better if you do two openings, one on the top and one on the lower part of the cyst, less failure, less reoperation if you do the second fenestration, because the superior fenestration alone tends to close. When we go down with the endoscope, by definition, we'll introduce the endoscope inside the cyst, so the fenestration will be larger. We will open, we will increase the flow, so we will reduce the risk of recurrence. So we will have a large open. You see, this is the open at the beginning. When you do with your scissor, with your laser, with your pouches, this is the open you get. And when you went down and you remove the endoscope, if the video will show you, at the end, you have a large stoma, which is much larger from what you had obtained at the beginning. So the chances of the risk of recurrence are lower. So less failure, less reoperation, but of course, more complication. There is a risk of potential anatomical damage, cranial nerves, basilar artery. So we have to be careful when the cyst is too small, you have to be careful beforehand where your floor is. These are, you see that there have been cranial nerve palsies, there have been problem with hemorrhages, a problem of growth hormone deficiency, salt waste sinking, hyponatremia, bleeding. So all the series have reported problems. Most of the cases were transient, but still you have to remember that the complication rate is higher than a standard ETV because of the anatomy. So in SAC2, with the mass effect, you might need the navigation to join the cyst because the ventricles by definition will be small. But overall, with the endoscopic fenestration, the success rate remains quite high. But you need to know that there is still, as in ETV, a risk of late recurrence with a closure of your stomas. In some cases, what is also important to know is that hydrocephalus can persist in type 1, even with an open stoma. So the problem in those cases is not only the mass effect, there is problem, more complex CSF dynamic circulation issue. And so you did a large stoma, you have a patent stoma on your MRI, but the decrease in size of the cyst, but still very large ventricles. And so you will need, in those cases, to go for a VP shunt. This is just an example. We did the stoma. We were happy, but still very large ventricle, symptomatic child. We need to do the put a shunt, and you see when this, even with the shunt, the ventricles remain large. So what are the take-home messages? Different natural history according to the subtype. The prognosis is related to the progression of the cyst. So it's very important, especially when you have an antenatal diagnosis of one of these cysts, to continue to follow up because of this risk of progression, especially in type 1 and type 3, with the occurrence of the hydrocephalus. Less true for type 2, but still you need to continue to follow them. Type 1, you will end up going for surgery for the hydrocephalus, most of the cases endoscopy, but remember that some cases shunt will still be needed. Same thing for the type 3 because of the mass effect they have. For type 2, when they are symptomatic, you go for surgery with narrow navigation. This is another series of successful ventricular cystostomy under navigation for those small cysts. First line endoscopy, less failure when you do 2 stoma, less reoperation, but more complication, of course. But don't forget that still a shunt may be a solution. Open surgery, less and less cases nowadays of open surgery for those cysts. The outcome is excellent in most of the cases, but as I said at the beginning, endocrine disturbances, they can still be there. Developmental delay, neuropsychological problem can still be there, even if you treat it very early, those cysts. Epilepsy also can be a problem. This shows you that in a minority of cases, we are dealing with a more complex developmental problem, all a brain problem, rather than arachnoid, isolated arachnoid cyst that you can solve with your endoscope. So thank you very much. If there are questions, we'll be happy to answer.
Thank you, Federicos. Very, very lucid presentation. So we'll move on to the next talk. The posterior process is by Levelin Padeachi.
Okay. Thanks, Nilam. Can you hear me and see my slides?
Yes, very much. Please go ahead.
Okay, first it's a big thank you to the organizers, Nelsie Zenon, Deo Pujari, Chandrasekhar, for a really fantastic session, and it's an absolute honor to kind of contribute in some way. So I'm going to talk about posterior fossa arachnoid cyst. In many ways, I think the lost sort of country cousin of the arachnoid cyst. And a lot of it has been kind of mentioned, the pathology, the physiology, all of those, pathophysiology rather, by Artur and Federico. So it gives me the opportunity to try and make up for some lost time, I hope. I'll try and stick to that time as best I can. So the outline of this talk is I'll go across the general aspects of arachnoid cyst, run through them, some of which have been mentioned before, and then the classification of posterior fossa arachnoid cyst, and then some of the management options. So the definition has been mentioned before. I'm not going to belabor that too much, but largely these are all almost always extraaxial. The fluid is almost identical to CSF. The cyst may compress adjacent structures, and the adjacent brain is almost always normal. So these are non-infiltrative lesions. You need to bear that in mind when kind of metering out the treatment option. Adjacent bone may be bowed just in terms of radiological diagnoses. The anatomy, the arachnoid, we've been through the cisterns. I'm not going to belabor that too much. For those of you interested in really good reading, this sort of literature, contribution by Knut Wester is really, I think, a must read for those who have an interest in this. It talks about the distribution of the posterior fossa, the diagnosis, and it's often important to remember that it's usually incidental following imaging for either antenatal events, macrocrania, epilepsy, developmental delay, or minor head injury. So these are the posterior fossa arachnoid cysts are usually picked up incidentally. The natural history is often unclear. There may be a history of minor TBI complicated by cyst hemorrhage. The management is variable, as I'll point out, and as you can see by the previous talks, there is no standardized kind of regimen or protocol, and you've got to individualize treatment. I think that's probably the most important. Endoscopy, as the previous speakers have highlighted, is increasingly an attractive option, but you need to bear in mind the circumstances where you work, your level of expertise, and I'll highlight that as we go along. The epidemiology, 60 to 80% diagnosed in childhood, usually in younger kids, male to female ratio. We've heard about 1% of all intracranial mass lesions. It may be familial, but and associated conditions are quite rare, but these are really sort of esoteric comments. The pathology we've heard from our tour, the arachnoid cells may be hyperplastic, is often collagen. The important thing to remember is the vascular relation. They often have quite prominent veins. So when you fenestrate these things, either these arachnoid cysts, either endoscopically or microsurgically, you've got to bear in mind the risk of bleeding. The mechanisms of expansion, there are a few which have been described. The osmotic gradient into the cyst, usually from a higher protein content. The ball valve mechanism, reportedly seen at endoscopy and usually kind of described in terms of delayed filling following cystoscopy. The active fluid production by the cyst wall itself, that's related to the neurosecretory ultrastructure in some cases, and then the theory related to pulsation-driven movement and expansion of these cysts. Also, in terms of the natural history, some of these may actually spontaneously involute. So the topographic distribution, supratentorially, like we've heard from the previous speakers, they could be sylvian, they could convexity, they could be interhemispheric, supracellular, like we've heard from Federico. And then the quadrigeminal plate, which I haven't really included, but I thought would probably be covered by the next speaker, they tend to bridge that gap between supra and infratentorial. But strictly speaking, the classification of posterior fossa cysts involves the cerebellar hemisphere, the midline vermis of cisterna magna, the cerebellar pontine angle, retroclival, which are incredibly rare, and I'll show a case at the end, and then the intraventricular cysts, which usually form part of a more complex pathology. Imaging is incredibly important here. Antenatal ultrasound for those diagnosed antenatally is very useful, increasingly becoming a diagnostic tool of choice. CT really just shows the kind of fluid. It's usually CSF and isodense. I wouldn't have thought there are many centers treating these which base their treatment modalities on CT. So MRI is an absolute necessity. The flare is useful, but the Fiesta and cyst sequence, the steady state sequence, depending on the system you have, I think is mandatory just to kind of visualize the membrane. Cine studies are increasingly, required, and we aim to use them in almost all our cases just to assess CSF flow before and after and how plan with surgery. For completeness, historically, things like CT cystoscopy and plain X-rays have been described. The differential diagnosis for a posterior fossa CSF fluid, it's a normal variant, so dilated subarachnoid cisterns, congenital lesions like Dandy-Walker malformations, which have criteria. I'll show an example as we go along. Acquired lesions like post-traumatic porencephaly, arachnoid diverticuli, tumors, particularly epidermoid cysts, parasitic cysts, most importantly, hydatid cysts, depending on where in the world you find yourself, is a very important differential diagnosis. Cysticercosis as well. And then supratentorial lesions, those that herniate, I left out the R, the apologies for that, into the posterior fossa. And this includes in the differential arachnoid cyst of the quadrigeminal plate and this phenomenon of herniation of the atrium of the lateral ventricle across the tentorium cerebellar. So posterior fossa arachnoid cyst, about a quarter of all cysts. The location in the posterior fossa retrocerebellar, most are in the CP angle, very small percentage retroclival, and in the fourth ventricle, there is exceedingly rare, but this usually forms part of a broader spectrum, multi-loculated complex hydrocephalus, or in the presence of a VP shunt in the lateral ventricles that is malfunctioning or dysfunctioning. So the retrocerebellar arachnoid cyst, there are two main forms, those in the midline and those that are slightly sort of posterolateral. The presentation is typically with raised ICP and the symptoms that go with it. Rarely cerebellar signs, suboccipital headache, and they may simply just have an occipital bulge, which has been described as well. The differential diagnosis, I've mentioned all of them before, also bear in mind a JPA, a juvenile pilocytic astrocytoma. These tumors usually have a large cystic component with a mural nodule. Hemangioblastoma as well, very rare in kids, I suppose. Dandy-Walker malformation, you've got to bear this in mind as a differential, and these are the classic features. I'm not going to spend too much time there. The isolated fourth ventricle, I think, is quite an important feature here. Typically, patients with a VP shunt in the lateral ventricle, but in my experience, having treated a lot of patients with multiloculated hydrocephalus, they seem to form part of the spectrum, and the treatment, in terms of how you manage the supratentorial component and how often you need to manage this infratentorial, intra-fourth ventricular cistern or a cyst within the cisternal space is quite an important discussion point. Maybe outside of what we're doing now, but certainly a discussion point. Aqueductoplasty, I think, was mentioned previously. This is a case I like showing because initially we treated just with an endoscopic fenestration, so transcortical, transventricular, fenestrated it, and like the literature has shown, these tend to kind of recur if you don't, and I'm going to play these sort of simultaneously just in the interest of time. So we then went back, put the scope in, found a sort of occluded point in the aqueduct. We then passed the catheter and fenestrated it here, and eventually anchored that via an Amaya reservoir supratentorially, and that sorted out the problem quite nicely, as you can see here. Chiari malformations, you've got to bear these in mind as well as part of the differential diagnosis, part of a completely different discussion, but you have to bear them in mind, particularly Chiari 3 and Chiari 4, which have large sort of cystic or encephalocele type malformations associated with the abnormality. CP angle arachnoid cyst, the presentation I think mimics almost completely CP angle tumors in adults, things like decreased hearing, tinnitus, corneal reflexes, facial pain. Late presentations are usually those of cerebellar signs and raised ICP. The differential diagnosis are the usual suspects here: an epidermoid cyst, cystic tumor, parasitic cyst, especially hydatid cyst, and then, like I said, the herniated lateral ventricle. This is the case. I'm going to skip over this in the interest of time just to move along. More complex malformations. This is the newborn with the frontonasal encephalocele. So you've got to bear in mind that these could be part of a more complex spectrum of disease. This again is the herniated lateral ventricle. I'll show a case. Is this supposed to be a fossa cyst or a herniated atrium of the lateral ventricle? It does, impose on the type of treatment that you would offer the patient. Hydatid cysts, like I mentioned previously, these you've got to bear them in mind very strongly depending on where in the world you are, particularly Turkey, Africa, South East Asia, India, South America, those sorts of things. And this is the case that I always like showing. If you can remove these in total, you've got to aim You've got to aim to remove them. This is quite a large cyst that we removed. But that's always the goal. And then very rarely retroclival cysts. This is a case of a 4-year-old boy who presented to us with progressive spastic quadriparesis, altered breathing, pattern of apnea. So this was the scan that he presented, the T2 SAG, and you can see that the prepontine cisternal space all the way retroclival, displacing the basilar. There is a lesion there, but it's very poorly and very ill-defined. So our CSF dynamic studies, the CINI studies, radiologists reported as flow across that, which I wasn't convinced by. But anyway, that was the report. We then kind of just maneuvered around the sequences, and you can see just by changing the windowing on the T2 SAG, you can see what looks like a well-circumscribed cystic lesion that extends retroclival, but really in that area. So there's no way that CSF could really be sort of passing through this. We then remove this. You can see it did a C3 to about 5 laminoplasty. And I'm going to move along the video quickly just to show you the cyst as it was removed. You'll see here, so we can move the cord laterally. This is our suction stim that I use just to stimulate the cord. Just with creating a little bit of space, the cyst almost evacuates itself. I was still concerned that this may be a hydatid cyst at that point. So we took the precaution of hypertonic saline, left the ketone albendazole, but eventually came back as congenital cyst. It was called a neuroenteric cyst. But I think one's got to bear that in mind, especially with the arachnoid cysts in the retroclival area. And as we remove this, you can see the happily sort of pulsating cord after that. So the treatment options are, like was pointed out, they can be treated conservatively. So with reassurance, I almost always try to follow these up with further imaging. So observation, I think, is pretty important because the natural history is difficult to determine. Where you think it appropriate fenestration, this can be either done microsurgically or endoscopically or endoscopy assisted microsurgery. Placing of a shunt, either cystoperitoneal or ventricular peritoneal. These are also options that need to be kind of individualized depending on the expertise available. And I find this this algorithm very useful, and this is kind of thanks to Graham Fegan who put this together. So if you follow this sort of algorithm, I think you can often make a reasonably sound type of treatment algorithm. So craniotomy, very, very, very important, very, very sort of quickly. Positioning is important. Always try to open in a way that will facilitate a watertight closure in the region of the retroclival area. Always try and preserve the ligamentous attachment to the spine of C2, which is why I showed that previous case. We tried to do that with that kid. I'm going to skip over these cases quickly. Endoscopic fenestration, I think I'm highlighting the point here that experience is incredibly important. So the point there is use the safest approach in your hands and remember to ask for help when needed. As a general philosophy, these treatment modalities need to be individualized. Always ask yourself why you're choosing the particular approach. Endoscopy is more ideal if the lesion is deep and brain needs to be traversed. But in superficial lesions where critical structures are involved, the craniotomy is ideal. Endoscopic, the options, we've listed them previously, probably outside of the scope of this talk. Navigation, I think, is a fairly standard issue for these sorts of things. We use the ultrasound routinely. This is just a quick video to show a cyst and how we use an ultrasound ventriculography just to show that, before and after, you can see the catheter here to ensure that we've fenestrated the cyst correctly. This kid as well, I'm going to skip over this example. The use of adjuncts. So Martin Schumann was supposed to chair this session, which is why I've used this video. We often sort of share these videos, Martin and I. The laser is part of a very useful kind of adjunctive tool. Here is showing, the laser for ETVs, which I haven't quite used them for, but fenestration of these cysts. The laser is incredibly useful. But again, what you have available is probably the best option for you. Shunts, these are still very useful options for cysts in the posterior fossa, either cystoperitoneal or ventricular peritoneal. It's the most straightforward treatment option, and you may see quite a dramatic reconstitution of the cerebellum in these cases. Things to bear in mind is with hydrocephalus, you should consider the option of shunting the cyst first where this is appropriate. Always think about the catheter position, particularly as the cyst collapses and the potential injury to neural tissue. In my experience, I've added this point because we were taught by Jonathan Peter to avoid the Y connector at all costs. It'll be interesting to hear other opinions, but I as a rule, almost always try to avoid them. To summarize then, posterior fossa arachnoid cysts, mostly they retrocerebellar. In the midline are the posterolateral and the cerebellopontine angle. They can be often incidental in terms of the diagnosis. The treatment options involve sort of a conservative observational approach, surgical fenestration, which can be either microsurgical or endoscopic, and shunts where appropriate. So the best option, I think, as a take-home message is it's the safest option in your hands. Remember that. And as one advances along your career, options that you learn or are taught become more sort of appropriate and more kind of safe in your hands. So this quote, I think, is quite appropriate. I did then what I knew how to do, but now that I know better, I do better. So it's always important to remember, like I'm going to say now, the safest option or the best option is the safest one in your hands. Okay, thanks to both the chairs for this session. I'll hand back to you.
Thank you, Levlin. Thank you so much for this overview. We're going to quickly move to our next speaker, Dr. Eduardo Yuko. Eduardo, are you here?
Yes, I am. Yes, I am. I'm just trying to share the screen.
Okay. We'll take all the questions at the end and the discussion.
Okay, can you see me?
Yes, perfect.
Thank you very much. Hello, everybody. It's such a pleasure to be. We have so many friends from all over the world, from the 5 continents here, discussing such interesting subjects. I wish also to thank Nelsie for the invitation and for such a tough subject, the other cysts, apart from the big 3. And I chose to call them the rare intracranial cysts in children. And they are really rare. You'll see it in the next few minutes, but they are always there. So it's an interesting topic to discuss. And I think the accumulated experience of all the services in the world must be of use, because they are really almost anecdotal. Then we have the big 3 cysts, arachnoid cysts in the middle fossa, in the supracellular region, and in the posterior fossa. And my predecessors have spoken very much about them, Federico, Arthur, and Llewellyn. And the others, what are the other cysts? The interhemispheric cysts, the quadrigeminal cysts, the cysts of the septum pellucidum, and the ventricular and paraventricular cysts associated to multiloculated hydrocephalus, and also the tumoral cysts. We know that these last 2 are not arachnoid cysts in the strict sense, but they share the same principles of treatment than the others, and they can be approached also by neuroendoscopy. So I think the main question is when to operate these cysts, more than how to operate them. We operate the symptomatic ones, of course, when they provoke intracranial hypertension, headaches, vomits, loss of consciousness, of course. Also, when we have an enlargement of the head size, but also when they provoke focal disabilities, and also the developmental, neuromotor developmental disturbances in the children. But it's not easy to identify sometimes. And the asymptomatic, they are really controversial. We operate them if they provoke an important mass effect. But if they are not operated, and we can see in the literature and in the personal practice of neurosurgeons around the world, a trend into a conservative conduct in these cases. But if they are not operated, we need to have a close follow-up for these children with the neurosurgeon to early detect if they start to have a mass effect or start to disturb the neuromotor and neurocognitive development of the children. And you have to count on our colleagues from the neuropsychology also to perform all these complex assessments. So the objective for all these cysts, at a first glance, they may seem an heterogeneous group, but the main objective to all of them is to provide flow, as we can see in the Panama Canal, not to accumulate CSF in the cyst, provoking intracranial hypertension. And if you look, we have to perform a communication between the cysts and cisterns or ventricles who have a free flow into the ventricular, into the CSF flow system. And if we look at the last annual issue paper from our society, the International Society for Pediatric Neurosurgery, we'll see a very nice paper from Nasser El Gandour from Cairo, describing a very extensive experience over 20 years of neuroendoscopy for intracranial cysts in children. But even here, we see that they are really rare. 87 infants over 20 years. So we have an average of 4.5 children each year. So in this casuistic, we have the relative incidence of the cysts, as we have already spoken about in the session. We can see that the cysts associated to multiloculated hydrocephalus are very defined, but they share the same principles of other cysts. They need communication to cavities that have free flow of CSF. As conclusion in this paper, we see that neuroendoscopy can have less invasiveness than the open craniotomy and less complications than shutting. That's our objective. I would like to share also a paper with our friend in Brazil, in Belo Horizonte, Minas Gerais, Alexandre Gianetti, 2012, who talked about interhemispheric arachnoid cysts. And we can see these beautiful pictures and seeing always the same principles of communicating the cyst with some cavity, following some trajectory with the endoscope. We can see the association of interhemispheric cysts with the corpus callosum malformation. So many children can start having disturbances in the neurodevelopmental compartment, but we may overlook a cyst because of the malformation of the corpus callosum. More recently, into 2016, a casuistic from a very high case-loaded service in New Delhi shows also a series of interhemispheric cysts, but again, over 4 years, only 6 pediatric cases. We have also the cysts of the septum pellucidum, and they are tricky because we see sometimes an enlarged cavity of the septum pellucidum, cavum of the septum pellucidum, and we may consider it as a variant of the normal state, but sometimes it can be symptomatic, and we have to pay attention to that. And we see that the endoscopic treatment of these kind of cysts are not a novel initiative. Once this paper is from 2005, and more recently, 2021, we have this beautiful paper from Giuseppe Cinali group about cysts of the septum pellucidum, having some beautiful volumetric studies of the cysts and verifying a good success rate. The group of Cinali also published this very important paper about the other intracranial cysts in 2013, where they explore the anatomy, make a very interesting review. And we can see again the association of the interhemispheric cysts with malformations of the corpus callosum. And talking about the quadrigeminal cysts, we can see some different types. Type 1 extending above and below the tentorium, type 2 restricted to the region below the tentorium, and type 3 going laterally, having probably some mass effect on the brain parenchyma. And this classification can influence the treatment choice, so it's very important to have this knowledge. We have also the ventricular and paraventricular cysts associated to multiloculated hydrocephalus, as in this paper by Professor Girocco and Caldarelli with Giampiero, Giovanna, and Luca. And we see this intraventricular cyst treated by endoscopy, communication with the ventricular system. We have a very nice result. We see this very challenging situation that every one of us face in our everyday practice. There's the communication of cysts derived from multiloculated hydrocephalus, but it can be approached by neuroendoscopy also with good results. But even if we cannot treat completely this situation only with neuroendoscopy, we can restrict the number of catheters that we use. You know, each catheter we can spare is in advantage of the child health. So some pros and cons: the use of neuroendoscopy in intracranial rare cysts. We have as pros shunt avoidance, the success rate between 70 and 80%, as showed in the majority of papers, less infections, less reinterventions, economic issues, and it's versatile. We can choose many different strategies when you have an endoscope to treat the rare cysts. As cons, we have a learning curve that may be long, but this kind of initiative, sessions like this one, and sessions of in-person training, as we had in Fortaleza in our last Brazilian Congress with Gisele, who talked about the training, and with Pepe Tinali, who came to participate in the session, was very, very nice, can short this learning curve. Spatial orientation can be challenging, and the availability of flexible endoscopes and neuronavigation linked to endoscopy may not be available in many parts of the world. So neuroendoscopy in rare cysts are effective, are safe, and are versatile. You can use it in many ways, and for example, can use endoscopic assisted surgery as we use in Fortaleza, in this 8-year-old boy with headaches and learning difficulties. It was a craniopharyngioma linked cyst, but it could be another type of cyst that we chose, for instance, to put a catheter. And in this 8-month-old boy, 32 weeks of prematurity, previously shunted, we have this very challenging situation. And the greater challenge here was a big isolated cyst in the posterior region. And I will pass it slowly. So we started with a septostomy, and then we progressed to enter the third ventricle cavity. We performed after that. We can see a very, very many anomalies in the anatomy. We performed the third ventriculostomy. And after that, we opened the posterior cyst, and we saw even a different color fluid. It was really isolated. So I would conclude with this advice from Professor Rarf. I advise against surgeons who are relatively inexperienced in neuroendoscopy undertaking the endoscopy treatment of hydrocephalus in this patient population. Competence and familiarity with the ETV should first be achieved in other patients where the anatomy is more straightforward. He was talking about ETV in myelomeningocele, but I think this statement could apply perfectly to endoscopy in rare intracranial cysts. And I thank you all for your attention. Thank you.
Thank you so much, Eduardo. This concludes our session, and we have a few minutes to take questions, if any.
Federico, can I ask a question to you? The suprasellar cysts, what is your strategy to follow them up, particularly for the endocrine disturbances? And what do you do when there is a recurrence? Is Federico there? Fine, I think he's... Federico, can you unmute? Okay, meanwhile, let me, Levelin, you've shown a beautiful case of retroclival cyst. And how did you decide to operate on that? It's a small cyst. Is it the symptoms that decides, or the size of the cyst that decides the surgery?
Yeah, look, this kid was a progressive spastic quad, like I showed in the slide.
Right.
And we did a sleep study on the kid, just because we had the option to do that. He had reported episodes of apnea as well. So, the kid was profoundly symptomatic. He's improved dramatically afterwards. But I think that the clinical indication, more than anything else, was the reason to take it out.
Thank you.
I have one general question to the audience. I think Eduardo and Levelin are still with us. How long do you follow asymptomatic arachnoid cyst? Does not matter what location, but how long do you follow if an asymptomatic patient occurs with no surgery?
Eduardo, maybe you go first, and I'll just add a comment afterwards.
Yeah, it's a very nice question, a crucial question with no exact response. I think it depends on the location. Yes, because we are more used to middle fossa cysts that don't progress. They progress following the literature only until 2 years of age. So if we find children that we follow for 2, 3, 4 years, we stay calm about the situation. But if it's in other locations, you can pay more attention. So every time the indirect signs, the head shape, the learning skills of the children, the talking every time with the neuropediatricians, the neurocognitive psychologists. But I think there is one novelty that in the future we could use. And Nelci and Ricardo Oliveira, who are in this session, and also Matheus Balesteiro from Brazil, are really involved in this sense. There is the non-invasive complacency, intracranial complacency measurement. So it's a non-invasive method you can use to try to assess how things are going in terms of complacency, who is an indirect sign of intracranial pressure. So I think it can help in the future.
So how often you do MRI for these asymptomatic cysts?
Yearly. And after we are very confident, we can say, come back here in 2 years and we'll see what we do. But in the first years, we can make it yearly.
Levlin, you said you had a comment?
Yeah, look, I just to sort of reinforce what Eduardo said, I'd follow them as long as we need to. I don't think it's an absolute radiological or clinical. I mean, I'm saying things that, all of you would enforce now. It's a combination of the two. I think, Eduardo, that's a very sensible thing to do. Initially, yearly, and then as they come back and they're clinically stable, I'd push it out to every 2 years. But I certainly think this is one of those lifelong relationships that you develop with patients.
Thank you all. I have one question. I think Federico is back with us, and then I think we need to close the session. Dr. Venkatramana, did you have a question for Dr. Dirocco? Or
sorry.
Yeah, Dirocco. My question was, how do you follow up this supracellular cysts? What is your strategy? And if there is a recurrence, how do you treat them?
Well, it's like for the ETV, I follow with MRI. Of course, and then the recurrence really depends, as in ETV, on the timing and reason. So if it's a recurrence because you did only one stoma and on the superficial part of the cyst and the stoma closes, then it's a redo ETV, a redo ventriculocystostomy, it's a redo procedure. If you have a recurrence of the symptoms with a patent stoma, it's a problem, as I said, of dynamics that we can have. I show you the case of large cyst despite a large stoma, despite the flow visible on MRI. And this it becomes an atrocephalus problem more than a cyst problem, and you need a shunt.
And it looks like there's a tendency, maybe in Europe more so, to operate on the patients with, middle fossa arachnoid for cognitive reasons, because there's a lot of neurodevelopmental cognitive testing going on. And I think, Federico, your group had done some tests on these patients as well, right?
Yes,
Could you comment?
All patients with temporal cysts or supracellular cysts and so on are also explored from the cognitive point of view. But as we mentioned, symptoms and signs depends on the age of the patient. So most of the cysts nowadays are discovered, and this is the main point I didn't stress too much on the difference between the temporal cyst and the supracellular region cyst, that the antenatal diagnosis is completely different. Sylvian cysts are very rare in the antenatal period. Supracellular one, no, they are seen. And in most of the cases, the diagnosis is very early for those reasons. So nowadays in Europe, we have a trend to have early diagnosis of supracellular cyst. Rarely they arrive to us with the bubble head. Rarely they arrive with the signs of puberty. Most of the cases, the problems are discovered in the young, in the first month, with the macrocrania, with the bulging eyes, with more hydraulic problems, and those are too young to do the neurocognitive testing. Neurocognitive testing are essential in the late diagnosis of Sylvian cyst, of course, for these reasons. So it's a little different, but yet the supracellular one can have cognitive problems, and those cognitive problems, sometimes they respond, sometimes they do not to the fenestration.
Thank you so much. If there are no other questions from the platform, I think we'll close the session and move to the next one.
Okay, thank you very much.
Thank you.
Thank you.
Thank you to all of the.
To all of you.
Wonderful.
Thank all
you.
the speakers.
Thank you. Just introduce the next topic, the prominent chairs, Dr. Schroeder from Germany and Dr. Morota from Japan. Thanks a lot and welcome. Very interesting session about case and discussion. Thanks for coming and thanks for staying with us. During this session, I just put on the chat the next link, Zoom link for the business meeting between World Federation and ISPN. If you would like to stay with us, I put the link here on the chat. Thank you very much.
Thank you for the kind invitation to contribute to this session. It's a great pleasure to be here. I want to welcome my co-chairman, Dr. Morota. I think we should go on very early. Pepe is the first speaker. I think Dr. Chinari is well known to every one of you. He is a very well-known neuroendoscopist, and we are curious to see your case, Pepe.
Thank you very much. Can you hear me?
Yes,
very well.
Okay. I will.
We can see two of you, but hear one of you. So that's.
Can you see my screen?
Yes.
Okay. This is a very, very simple cases that got a little bit complicated. It's a neuroendoscopic septum pellucidum cyst fenestration. It has already been described before during this session, but it's a good way to go back to see this and also to see the indications. It's a female, 8 years old, with a very normal complaint of 1 week before admission. So she comes to the emergency room in our hospital. She got a CT scan because of the headache, and we see a biventricular hydrocephalus, and there is a papilledema of the ophthalmologic evaluation. So there is a clearly intracranial hypertension, no other signs of neurological impairment. And the contrast enhanced MRI, here we can see the MRI without enhancement. There is clearly a cyst of the septum pellucidum, of the anterior half of the septum pellucidum, that you can see very nicely here. Only the anterior half of the septum is bilayered and not the most posterior part. And this is the coronal section, showing very nicely that there is some bulging of the layers of the septum, and that there is also, here it is very clear, an almost complete obstruction of the two foramen of Monroe. It is impossible to see the foramen of Monroe wherever you look for them in this flare, and clearly the two layers are bulging. So the indication in this case is clear. It is symptomatic. There is papilledema, and decided, of course, for a surgery that was done the same day. Just give a look to the rapid classification. I'd strongly advise to give a look at this paper from Shane Tubbs from 2011 that classifies the midline cyst with the cyst of cavum velum interpositum, cavum septum pellucidum, when it is the anterior half of the septum pellucidum, or cavum septum pellucidum and the cavum verge, where the cystic dilatation is extended to the whole length of the septum pellucidum. It is very important to have clear this simple classification of the midline, not to confuse them with the interhemispheric cyst associated with the genesis of the corpus callosum, and especially the second and the third part are very frequently associated, especially in adults, with troubles of the behavior and psychiatric symptoms. So once this classification is clear, our case was a straightforward indication, so we decided for a surgery, and these are the papers that have been already cited in the literature, so we will go ahead. And this is the planning that was done in the emergency room in the night during to do this case. As you can see, the planning is very good because the trajectory hits the frontal horn in the most convex part at the level of the outer part of the ependyma, and the trajectory is intended to perforate both the first layer and also the second layer. As you can see, the bar hole is much more lateral if compared to the standard bar hole that is done normally in endoscopic ventriculostomy, and for this reason is absolutely mandatory. This is the navigation trajectory. You can see hit the ependyma in the most convex part, crossing the first layer and then crossing the second layer. Surgery was basically uneventful. This is the after entering the ventricle. This is the fenestration of the right cyst wall. We do it with a laser. It's much faster and much cleaner. Here you can see the right septal vein and the right thalamostriate vein. You see how this deformed is the foramen of Monro. Here we are entering the cyst. We are performing the fenestration of the second half of the cyst wall. And this is the contralateral ventricle. And we enter into the contralateral ventricle. There is no damage to the parenchyma of the thalamus of the other side. So it's very clean surgery. The veins of the other side, floor that was not very smart to do, but has been performed, but has been rapidly abandoned. This is the core fissure with the two internal cerebral veins. So this attempt certainly should not be completely open at this time, as you see nicely, that there is absolutely no obstruction. And this is largely sufficient for every cyst of the septum pellucidum, very large fenestration of the first layer, very large fenestration of the second layer, and everybody is happy. But the postoperative MRI shows certainly that there is a good decrease in size of the cyst wall, as you can see. Here, there is no more bulging of the two layers. Very nice opening of the first layer, very nice opening of the second layer. But we had a bad surprise to see that there is a contusion of the right caudate nucleus that is very clear on the coronal section in the MRI. And this was quite unattended because we had absolutely no bleeding during ventricular entry, and the ventricular cavity was found without absolutely any problem. And probably it was, the bar hole was done at the same point where it was intended to be in the neuronavigation, but probably the trajectory did not hit the ventricle exactly in the most convex point. And as you can see, it is tangential to the surface of the caudate nucleus, creating a small contusion of the caudate nucleus. Fortunately, that was completely asymptomatic, so we were very happy. And the patient was very nice and very fine in the earliest days. But then she started to alternate a state of wellness with episodic severe intermittent headache. We were very close to send her home, but finally, because of this intermittent headache, we decided to perform a CT scan immediately before discharge. The CT scan shows that there is the contusion of the right caudate nucleus, but above all, there is a triventricular hydrocephalus with a bilateral ventricular dilatation and the dilatation also of the axial diameter of the third ventricle and of the temporal horns. So we decided that something was wrong, and we were very close to implant a ventriculoperitoneal shunt and classify this as an endoscopic failure. But before the implant of a VP shunt, we did not understand why these things was going wrong. And not understanding, we performed the MRI, and we saw that there was clearly on high definition sagittal images, there were some debris at the level of the infundibular recess. This could not explain the hydrocephalus, probably related to the contusion of the caudate nucleus, and the debris also from the perforation of the two layers of the cyst wall, but also there were debris at the entrance of the cerebral aqueduct. So, and this was only evident in BFFE sagittal sequences, that is a higher definition than drive sequences, very close to the cis sequences that you have in the Siemens. So we decided that the cerebral aqueduct was impossible to see and to visualize because of a very large massa intermedia. So we decided to just make an intraventricular lavage and make a safety ETV in this case. And doing the safety ETV, it was very clear that all these debris were certainly circulating inside the third ventricle. This is the infundibular recess that is full of debris, probably some small clots or some debris of caudate nucleus parenchyma that deposited at this point. The ETV is not very easy in this case because the third ventricle is very, very thin, but basically it was an uneventful ETV. And here you can see with the DEC forceps, this is our preferred instrumentation. And then we dilate the stoma with the Fogarty dumbbell-shaped balloon, neuro balloon. And this is the ETV with good visualization of the cistern and basically resolution of the problem. So this is the postoperative MRI. This is again the very good opening of the cyst, and you can see that there is no more debris at the level of the infundibular recess, no more debris at the entrance of the cerebral aqueduct, and above all, there is a very good flow at the T2 tubo spin echo sequences in the cerebral aqueduct, showing the recover circulation of the CSF. She was discharged on 6th postoperative day without headache, no new neurological symptoms, and this occurred 2 months ago, and she's now symptom-free. So conclusion, navigation is mandatory, but can still fail. This patient was done with the navigation trajectory was perfectly okay, but there was a failure in the navigation, probably 1 or 2 degrees in the trajectory, and the endoscope hit the caudate nucleus and create this complication. Certainly, you should try to enter the ventricle always in the most convex point, avoid to be tangential to the direction of the ependyma in order to avoid subependymal dissection from the tip of the endoscope. After perforation of both layers, check for the Monro permeability, because you have to be sure that you have opened not only the cyst but also the Monro, otherwise your circulation of CSF is not complete. And above, for every surgical procedure, always look for explanation when things are not clear with high definitions MRI. Thank you very much.
Thank you, Pepper, for this very instructive case, very nice case. I agree with you completely that the CIS imaging, what we have in Greifswald, is very, very helpful in finding some membranes or cysts, like Levelin has shown, which is not visible on a normal T2 weighted image. It's very helpful. And when I use this approach for colloid cysts, I always come from far lateral. And then the trajectory is exactly what you do, but my actual perforation or my trajectory to go into the ventricle is not down exactly to the choroid nucleus, but I go up. And then when I'm in the ventricle, I tilt the endoscope down, and then I push the choroid nucleus a little bit more down to prevent what happened in this case. But very interesting. Are there more questions?
Yeah, we use flexible endoscope in Japan, and so even if I use a flexible endoscope, I try to approach from the lateral, usually more than 7 centimeters from the midline at the line of the lumen temporalis, and then go into the ventricle and make the fenestration. So this is the difference between the flexible and the rigid endoscope, but still we go to the lateral, from the lateral here.
Yeah. Are there any questions?
I agree with that.
From the audience? Which we cannot see? Pepper, you are double.
Yes, yes.
That's good to have a duplicate.
There is nothing in the chat box, Henry. No
it is to
No, in the chat box we have no questions.
Can I have a question?
Yes, sure.
Yes, Pepe, thank you very much. It's a very interesting case, I think. Maybe you hold the endoscope in your arm, or you hold some holders.
No, I always do a freehand endoscopy, except when I use the endoscopic catheter. But otherwise, all the procedure are freehand.
Yeah, I think so. So I remember that 20 years ago, I discussed about this injury with the injury of the coated with the shaft of the endoscope with Professor Penexi. Yeah, I remember that. That sometimes when we introduce the endoscope in the ventricle, we want to see everything. So you see the septum, and after that you change the direction to the foramen magnum. So at that time, the shaft of the endoscope is attached to the caudate. I think so. But it's very, very educational case, I think. Thank you very much.
Thank you, Kanish.
Thank you very much. Very instructive.
Very interesting case, Professor Senali. Is there any specific landmarks you choose in opening the wall of this cavum, particularly on the opposite side, or is generally go by the trajectory?
Yeah, thank you, Neil. This is an excellent question. But when I enter the ventricle, of course, I rely on my trajectory, but I always do a match with what I see. If on my trajectory there is a vein, then I choose the most transparent part of the septum. Always, I rely more on what I see than on my navigation. And also for the second layer, I know that the lower I go, the higher are the possibility to hit the thalamus. So I try to remain as high as possible, also in the second layer.
Thank you.
Yeah. What are you doing when one ventricle is wide and one is small? Some people say I come from the wide side, but then I have no distance between the distal layer and the wall of the ventricle. That's why some people say I go through the smaller one because I can perforate it easily. Nothing is behind. What is your preference?
My preference, I don't agree with this, especially in pediatric cases. When you have a very dilated ventricle, isolated ventricle, you also have damage to the white matter. So I always prefer to enter into the ventricle through the white matter that is already in failure, that is already damaged. I don't want to use a trajectory into the healthy hemisphere. In this case, I always manage to find the way to perforate the second layer. You have to be careful. You have to use a very low power laser, or you have to use an instrument without any heating power. If you want, you can also use the DEC forceps. But I always try to make a trajectory through the bad hemisphere.
Yeah, I agree. I do the same. Thank you so much, Pepe. We have to continue. So the next speaker is Dr. Chatterjee from Calcutta. Is he here with us?
Yes, indeed.
Yeah, hello, Sandeep.
Hi, how are you?
Looking forward to your case.
Okay, I'm not going to present anything very exciting, I'm afraid. But, okay, can you see my screen and can you hear me?
Yes.
Right. Well, I'm going to, first of all, thank you very much, Nelsie and Shekhar, for this invitation, and a Happy New Year to all colleagues around this planet. I'm going to present to you a case which is nothing exotic or exceptional, but something which highlights the sort of maximum frustration level that a pediatric neurosurgeon can face in his practice. And this is an 11-month-old baby who's born premature, has sepsis in the immediate postnatal period, develops meningitis, and comes to us with post-meningitic hydrocephalus, been in a pediatric intensive care and a pediatric ward for 4 months of his 11-month life. Multiple ventricular taps done in 3 different hospitals because he was in a place far away from the city and then gradually moved to the city and to indeed our own city. And this is the MRI with which he presents to me with a large head. Now, I don't know whether you see this very often in Germany, but in my part of the world, this is something that we do encounter maybe once every 2 months, which is perhaps far too often. So where do you start and what do you do when you have a child like this? Just to share his CSF, my routine policy is to first do a ventricular tap, check what the CSF is. And as you can see, there's very low glucose, very raised protein, a cell count, which is about 28. But the child clearly has sequelae of post-meningitic hydrocephalus. The CSF is still infected. There is an ongoing infection. And what do you do in this situation? Well, I'm going to be very quick and brief, but here are your options. You can put an external ventricular drain, carry on with intravenous antibiotics. Some people would suggest intraventricular antibiotics. You can leave a ventricular access device. Of course, you can do regular ventricular tapping. That's already been done by the neonatologists and the pediatricians a number of times before the child gets to us. And of course, the last one is my favorite here, which is the ventricular subgaleal shunt, which sounds an atrocious thing to do in this situation. But this is something that over the years we have felt best to do. But before I do that, of course, I get the endoscope and try and clear the CSF. First of all, it is very turbid. I irrigate and irrigate till we can get some vision. And then it looks as if you're really under the deep ocean when you look through that endoscope, and all these multiple loculi all over the place. And of course, my own policy is to try and get as many cavities into one as possible. And of course, we fenestrate. We do use navigation, but we fenestrate as many cavities as we can, try and make it into as few cavities as we can, and then put in a ventricular subgaleal shunt, which of course you can see this. We use a low pressure shunt in some of the children. Very rarely we use just a plain tube, but most often we use a low pressure shunt. You can see the CSF is still turbid. And the reason why I use a low pressure valve for a ventricular subgaleal shunt is for 2 reasons. Number one, with these very emaciated, poor nutritional status babies, one thing that happens is you don't want too much of CSF to collect in the subgaleal pocket suddenly, because if it does, then it leaks through it, and that's a disaster story. And the second thing is if you have a valve, you can aspirate that valve and get an idea about what's going on with the infected CSF afterwards. So this is what happens 48 hours later after we've done the ventricular subgaleal shunt, and we get a CT scan. This is what it looks like. It wouldn't win a prize in a beauty contest, but definitely we see more brain than we were able to see in this child before. And we give the child 2 weeks of intravenous antibiotics. I go back again, and this time I aim to try and do an endoscopic third ventriculostomy, which is much easier said than done, but we do manage to do it. It looks awful, as you can see, because the floor of the third ventricle looks a little bit like what the dog brought home last night. But you can still, with patience, negotiate your way in, get endoscopic third ventriculostomy done. We leave the ventricular subgaleal shunt. That was the post-op scan. And we thought everything was fine. We were going to leave the ventricular subgaleal shunt till the CSF cleared, and then we were planning to take it out and then decide whether the child needed a shunt at all or not. But 4 weeks later, the child comes back. We managed to discharge the child at this stage, comes back with obvious infection. The ventricular subgaleal shunt is working, the pocket is still filling, but there's obvious infection. And of course, the CT scan looks horrible. So what do we do now? This is the MRI. And of course, what we decided to do, and this is something we've done a few times, and this is something that I was tempted into doing by Professor Shizuoi many, many moons ago. We put in dye when we're there and try and see how many of them communicate with each other. And then again, we use the endoscope to try and get fenestration done. We had to do repeated staged fenestrations to try and get all these cavities together. My own preference for navigation is to use the shunt introducing device through the endoscope, and that seems to work very well and gives you a nice trajectory to look at. This child by then has a large subgaleal pocket, a subgaleal shunt here, and another subgaleal shunt on the other side. And we're trying to take everything out. And of course, try and plan to make as many cavities again into one. I'm just going to rush through this a bit and skip this video in the interests of time, because some of our colleagues and chairpersons must be well over midnight in their time. And this is what we end up with immediately post the third fenestration. So we've certainly managed to get the ventricles down, a lot of brain available, and a lot of air and CSF in the immediate post-op scan. And just to tell you, 7 weeks after we started, this is what it looks like. The child by now has CSF, which is clear. The child is thriving, actually eating, smiling for the first time. And this was the final scan that we decided at this stage we would not do anything further. There are no more shunts. There's an endoscopic third ventriculostomy, which we did a second time, or redid, and took all the shunts out. So there's no shunt, and that's the ventricles. And if you compare with what we started with, 7 weeks after a number of efforts, this is what we reached. And I thought I'd just share with you, we've been doing a lot of these VSG shunts with endoscopic fenestration in post-infective hydrocephalus, and we published this just a few months ago in Child's Nervous System for those that may be interested. So just to conclude, I'd say one of the questions that this case raises, I'm not going to say what it answers, but is a subgaleal shunt a good option in post-infective hydrocephalus in the presence of infection in the CSF? Repeated fenestrations, repeated VSG shunts, does it work? It requires a lot of neurosurgical patience, both on the part of the neurosurgeon and the parents. And what alternative methods of treatment could our erudite panel suggest that I could have done instead of resorting to so many procedures? Thank you very much, and I look forward to your opinion and questions.
Thank you, Sander, for this very instructive case. And to answer your question, of course, we don't see it very much in Germany, but we had also a case with a ventriculitis in a newborn, and we had to make 24 surgeries because always there were new fenestrations, new cysts. It was a disaster, but finally the child is good. She has a whippy shunt, but she's now, I think, 4 years after the surgery. So, of course, she has some retardation in her development, but she is quite good. So I think we should not give up. And it's your case showed very nicely. Initially, it was almost no brain, and finally, you had a good brain tissue. Yes, it is not bad. But I think the follow-up is still too short. I'm afraid that the child maybe require a shunt later on, because we had some patients, initially you thought it was good, and then after some years, it was more like I don't know, maybe an arrested hydrocephalus, but finally shunt was required. But you know better, you have seen so many patients. What do you think?
Henry, this is exactly what I told the parents, and I always tell the parents that for the moment, let's get all the tubes out of the head and let the child live happily. But remember, one day you're going to have to come back, and it's very likely they're going to have to put in a ventricular peritoneal shunt.
What do you think about this irrigation technique? Some people say we have a close collaboration with Cairo, and they have a lot of these infections. So they put one tube with inflow and then one is outflow, and they rinse with antibiotics.
Yeah, I have to say we did try it very briefly, and I somehow wasn't very excited about it and gave up. But for these patients, we do a lot of irrigation. You know, the very first procedure that I showed you have to irrigate for a long time before you start seeing anything in that ventricle, because you've got turbid CSF with a high cell count, high protein, and it's you just have to be very patient and irrigate before you start seeing the world around you.
Yeah. Thank you for that case. Any questions from our colleagues?
Thank you, Sandeep. Sandeep, fantastic experience. Thank you. Your paper and your experience of ventricular subgaleal and ventriculitis and infection changed dramatically my way of seeing this kind of technique. I expanded that, and I was quite incredible when discussing a few years ago with other colleagues from Latin America, but I must admit that it's a fantastic technique to take time, much better than external drainage. So it's just thank you for publishing this and for the excellent results so much.
Thank you, Pepe. Of course, you know that you've been my role model for a lot of these endoscopic procedures.
Thank you, Sandeep. Nice case. I don't have experience on subgaleal shunts, but I do have good experience on irrigation. Henry, if you remember, when you visited my department, we had devised a pump, which irrigates and automatically drains with the antibiotic solution. You get a very good result within a week's time, and then we go ahead and do the penetration. My experience, rather my guess is that probably we can reduce the number of interventions by the technique. So that's what I personally feel, but we don't have a large data.
Okay, thank you. Very interesting case. I hand over the session to my co-chairman, Dr. Morota.
I have one thing to talk. Sandeep, congratulations for your excellent outcome. And the ventricular subgaleal shunt is very much working, but once if it doesn't work, maybe we can apply both ventricular subgaleal shunt and placement of CSF reservoir. That would make sure if the subgaleal shunt doesn't work well, you can remove the CSF from the CSF reservoir. So I usually combine both together at the same procedure.
So Nobu, this is exactly what I said. Just because we were concerned about this, that's why I use a low pressure shunt with a valve. So it works as a reservoir as well. So if I have any doubts, I can puncture the valve and take the CSF off. So I don't need to put in a ventricular access device separately from my ventricular subgaleal shunt. Because unlike you, we don't use just a plain tube. We use a low pressure shunt, which has a valve, which you can puncture just like a ventricular access device. And that's why we decided to do this, because it gives you access. You can get that CSF off whenever you want. There is another reason why we use this actually, because there are some patients, and those of you have read our publication recently on this. What we tend to do is at the end, we percutaneously just tie up the end of the ventricular subgaleal shunt, and we see if the child can manage and the head circumference is not increasing and the ultrasound shows there is no ventricular megaly. Then we take it out. And certainly in certain cases like post-meningitic hydrocephalus, we've been able to reduce our shunt implantation from at one point about 87% down to about 63, 64% by just doing VSG shunts and then removing them after tying them up after a few weeks.
It will be interesting to see the intellectual outcome of these children,
Absolutely.
How functional is the brain that is recovered from all these insults. So that would be interesting to see that.
Okay, Sandeep, I'd like to make a comment. First of all, very, very interesting, your case, and as Chinali said, change our mind, because we have some experience using ventricular subgaleal shunt, but using for prematurity and hemorrhage for prematurity. But I never used this surgical technique for multiloculated hydrocephalus. So very interesting. And did you consider in this nightmare case, this complex case, as you showed, doing a small craniotomy to make enough hole? Because I have an impression when using a neuroendoscopy that our hole is very small, and frequently you can see closure of this hole. In this complex case, sometimes, of course, it's not common, it's not frequent, but in some cases we consider doing a small craniotomy and make a hole by microsurgery.
I couldn't agree more with you, Ricardo. We've actually done this ourselves a few times in complex multiloculated hydrocephalus. So we've done a small mini craniotomy. In this particular case, we did not do so, though. But I completely take your point. It is sometimes necessary to have a bigger opening.
Yes.
Sandeep, just a quick comment. Thanks for your fantastic case. I'm again, like we said before, huge fan of the ventricular subgaleal. I don't put in a valve, so I think like Morata, we just sort of into the space. Just two questions on these complex cases. We probably see, well, probably about as much as you guys do, I think. The value of the ventricular tap beforehand. I mean, initially when I started out, I used to do that, and then I realized it's a little bit, not that useful because each compartment has its own complexity of CSF. And then the value of the third ventriculostomy, I stopped even trying to do that in these complex cases. Did you find that useful, or why did you think that would help in that particular case?
Well, the answer to your first question, I definitely think a ventricular tap and CSF assessment is very important in these patients. And I tell you why, Llewellyn. We have a large number of patients that come to us with what masquerades as aqueductal stenosis, and you have a triventricular hydrocephalus in an infant who's 6-7 months old. And we just started doing, this was a study we published in 2002, I think, when we started doing ventricular taps in every child who did not have a history of meningitis. So every infant that came to us with a hydrocephalus without any obvious history of an infection, we did a ventricular tap and looked at the CSF, and to our surprise, we found that 58% of them had evidence of infection in the CSF. And of course, you know that Benjamin Waff published a similar study a few years later, and they showed from Africa that, again, if you did ventricular tap on infants, about 60% of them were post-infective. So I think there's a lot of post-infective hydrocephalus there in neonates and infants that masquerades as an aqueductal stenosis, and it isn't, at least in our part of the world. And it showed that it's almost half of them that you think should have no history of meningitis actually end up having CSF, which is meningitis. So a ventricular tap, in my book, nobody gets to go to have an endoscopic third ventriculostomy or ventricular subgaleal shunt in my department as an infant, unless the infant has a CSF study from the ventricles.
Okay, thank you. So we have to continue. Yeah. Dr. Morata, do you introduce the next speaker?
Okay. So we move on to the next presentation by Dr. De Oliveira, please.
Thank you, Dr. Morata. Thank you, everyone. So happy New Year. I will choose two cases. One is an unusual case, and the other one is a very frequent case that happen even if we are beginning in neuroendoscopy. So we will start for the unusual case. It's a little bit, it's a very rare case. It's a 5-month-old boy. He presented sudden irritability, vomiting, drowsiness. So the initial investigation was done with ultrasound and CT that showed cephalus, as you can see here in these images. And at the beginning, the child had a spontaneous recovery. But we also investigated with an MRI that showed, as you can see here, this cyst attached to the third ventricle. So we consider choroid plexus cyst. And this is very interesting because how can you explain this clinical onset of the child? Because of the pendulum swing. So the cyst move closed to foramen of Monro and cause hydrocephalus, and then again moved go back, and the child recovered after this movement. So in a high resolution image, the cyst is quite clear here, as you can see here. And we consider, as I said, choroid cystic plexus, and we did a neuroendoscopy approach. So you can see here the choroid plexus and the cyst and the membrane of the cyst bulging in the foramen of Monroe. So we open, and you can see here the close with the choroid plexus, and we try to coagulate the membrane of the cyst and then remove it with a scissor to unblock the foramen of the Monroe. So it's not, it's very rare choroid plexus cyst causing clinical symptoms, as you can see in this child. So we did completely remove of the cyst, as you can see here. Pay attention, doing a very carefully with the arteries irrigated the choroid plexus. So you need to coagulate it before to make a cut, so, the bulging of the cyst. So we remove it completely. And then we finish the procedure with endoscopic third ventriculostomy, just to complete the procedure. So the child presented, as I showed, an acute triventricular hydrocephalus in children with an apparent absence of clear cause should be accurately investigated for third ventricular cyst formation. So our radiological diagnosis of choroid plexus cyst can usually be obtained by MRI sequence. It was published by Chinali and group in 2016. And this is our control MRI after 3 months without a cyst and the complete resolution of the symptoms. The other case is a very common problem that you can see when we are starting on neuroendoscopy. So a previous 4-year-old boy was admitted in the emergency department with a 1-month history of headaches and vomiting with normal neurological examination. MRI showed a posterior fossa tumor and a hydrocephalus, and initially he was submitted to external ventricular drainage and tumor resection, followed in the next days by ETV due to external ventricular drainage dependence. So we removed the external ventricular drainage, but we also see a persistence of hydrocephalus, and we decide by a ETV. This, however, control MRI revealed a persistence of a ventricular dilatation and an absence of CSF flow, and then a revision of the ETV was performed. So as you can see here, we observed Liliequist membrane that was not open at the first procedure. So we redo our endoscopic third ventriculostomy, opening the Liliequist membrane and communicated in this moment treating the hydrocephalus. So this is a very pitfall that we can have at the beginning of our history on neuroendoscopy. So when we leave behind the Liliequist membrane, so it's very important to check the interpendicular cistern after open the floor of the third ventricle, and to be sure there is no existence of the Liliequist membrane, because it's a very frequent cause of failure in the ETV in some months of procedure. So we open the Liliequist membrane and we solve the problem. This is the main steps of the procedure: open the persistence of Liliequist membrane. So thank you so much. It's a very simple case. And the first one is very unusual, but the second is very common to happen with all of us. Thank you.
Thank you very much. Okay, so you have two cases for presentation. So the first case is called the fructal cyst in the third ventricle. Did you think you need to do some septostomy for sure to make communication between both ventricles, or you just remove the cyst and that's enough? You're sure, so you didn't do the septostomy at that time.
Yeah, we did not think about to do a septostomy. We found the cyst clearly blocking the foramen of the moral, and we removed the cyst, and then we enter in the third ventricle, and you can saw that it was free of the cyst, but we did not perform a septostomy in our procedure.
Any questions?
I have a comment.
Sure.
For the first case, I think it's very ideal if you make a bimanual technique, because as you mentioned, you have shown it nicely when the cyst is falling down to the choral plexus and the fornix, and you have to cut. Then it's difficult, and you have to be very careful that you don't cut to the vein or to the fornix or the other structures. If you have a bimanual technique, you take a forceps, you lift it up, and then the pedicle of the cyst is nicely seen. And then, via the main channel, you can introduce an bipolar coagulation and then scissors, and you cut it. So I use it very frequently for colloid cysts, and then you have not the risk that you cut to the structures. And in the second case, it's also a very important message from you that we always have to open the Lilliquist membrane. And you have nicely shown when you go too close to the clivus, you end up in the subdural space. So you have seen in the video you showed this membrane, and the first opening was too far to the clivus. You are in the subdural space, not in the subarachnoid. And then the second opening behind the membrane was in the subarachnoid space. And that's why it's so important that you have to see the basilar artery after your opening. Very nice.
Yes. Henry, okay. We talk about the first case first. Then we talk to the second case. Okay. Okay. Any question to the first case? Okay, please.
Very, very interesting. And we have in our continent cystic cysts presenting exactly like this, blocking the foramen of Monroe. But of course, the technique is completely different. You need to move the cyst, mobilize around, and then take it along the scope so that you don't drop the cyst into the ventricle. Pick it up and then take it along with the scope. So that's the way we remove it off, and then we have a very good result. Very nice.
Yeah, we use this when it's very rare, but sometimes it happens with neurocysticercosis.
Yeah.
When we have some cyst circles, we can use this technique to backward with the cyst. Henry, it's very interesting, but your comment using the bimanual technique. So I agree with you. The problem in for this case, we use a gap endoscope. So we don't have two work channel. So it's really difficult sometimes because you need to change frequently. You need to coagulate and then to cut the cyst. So when you have two working channel, it's easier to grab the cyst and then to cut. It's better. I agree with you.
Okay, thank you. So we move on to the second cases. My question is that in the posterior fossa tumor with hydrocephalus, I usually do the ETV first and then press a external ventricular drainage and then remove the tumor. The first you do the ETV, then you can sure the CSF is clear and you can see the Lilliquist membrane under the third ventricular floor. So you can go to the opening the Lilliquist membrane at that time. The external ventricular drainage is just for sure to stay 2-3 days. and there is no increase of the interventricular pressure, then you remove it. So the tumor, so after, in this case, you did the ETV after tumor resection. That means that somehow the CSF is congesting, and you can't see the bottom of the floor of the third ventricle after opening. So that's the reason why you leave the reduced membrane unopened. Yeah.
Yeah, probably. Yeah, it's interesting. Usually, in this case, in our institution, we have two hospitals. We have an emergency hospital and another hospital that I'm here now. And we do our elective case here. And sometimes this case arriving in the emergency unit. And of course, who is in charge will manage this case first, the hydrocephalus. And in this case, they put an EVD, and then we operate the tumor 2 or 3 days after EVD. And then we try to remove it because the surgery, we completely remove the tumor, we unblock the CSF pathways, and we try to remove the EVD, but the patient persisted with symptoms and with the hydrocephalus. And then we did an EVD, a later EVD. Was another assistant that did this. And as I said, it's in our beginning of our experience. Sometimes it's very difficult to check the interpendicular cistern, and you can leave behind some membrane. And after some months, with the persistence of hydrocephalus, it's another message, a very interesting message. It's doing an MRI, a control MRI, and if you didn't see the flow void in the MRI, the policy is checking again your EVD. So, but when I can in posterior fossa tumor, I started by an endoscopic third ventriculostomy. In case that the patient arrived very symptomatic and in an emergency situation, we also use an EVD. But the most important is to treat the hydrocephalus. Doesn't matter which technique we will use it, but the important is to recognize the hydrocephalus. That's a life-threatening condition.
Thank you. Any comment or questions? No? Okay. Thank you very much, Ricardo. We move on to the next presentation. Thank you. So the next presentation is Professor Sabrini from Italy. Please.
Can you hear me?
Yes.
Yes. Okay, good. So thank you to the organizers for having me, in particular for having given me the possibility to see so many friends all together. So we move back to other cyst cases. This is a 15 days old female, which actually had this neonatal ultrasound that was based on prenatal 32 weeks finding that was very similar in terms of pictures. She had a normal head circumference, normal anterior fontanelles, and she underwent in another hospital to this CT scan. In this CT scan, we gave importance to two things: a quite edematous cystic lesion in the supratentorial space, actually, and a smaller cystic lesion also in the posterior fossa. So we obviously submitted the patient to this MRI, and this was the picture. Again, a multiloculated paraventricular cystic lesion, which actually was giving significant edema on the surrounding structures, surrounding brain structure. The suggestion from the radiologist was that this was a desmoplastic infantile ganglioma. Well, based on the experience that generally for desmoplastic infantile gangliomas you do see after contrast or even in this PSA images a nodule which is sustaining the cystic part. We were not very much convinced about this option, and pushed a little bit by the lower age and by the fact that in spite of looking patients looking quite good, the cyst was creating a significant edema on the surrounding brain. We opted for an endoscopic exploration of the cyst and taking samples from the cyst wall, because it's not usual to see this edema for arachnoid cyst in spite of knowing the possibility of paraventricular arachnoid cyst, taking a sample from the cystic walls. So that's what was our plan, to go inside the cyst from its most superficial part up to the ventricular surface. I will not show the video, but I will show you some images at the entrance on the surface of the cyst, the opening with the laser coagulation of the wall of the cyst, the sample of the outer cyst wall that we took. Then we entered inside the cyst and we looked at under neuronavigation to its border with the ventricular walls. That was seen like this, a thinner membrane on the deeper part of the cyst, confirmed our position that we were near the ventricular surface, and opening again with laser coagulation and enlargement of the hole up to when we were able to see inside the ventricular walls the parotid plexus. So this was the surgery that we planned to do, and this was the post-operative MRI 48 hours. This is just a sponge along the cortical tract. This is the ventricle that was enlarged. Still we see a lot of edema around, and histological diagnosis was quite a little bit surprisingly, because again, we were not actually familiar for looking at this kind of cyst as arachnoid cyst because of the significant edematous reaction on the brain. The diagnosis was arachnoid cyst with, again, in this case, however, sporadic neuroepithelial elements. Based on this diagnosis, we decided for a follow-up of the small girl. 1 month after surgery, however, we saw because we did another MRI, because the girl developed a slight left hemiparesis without cranial nerves involvement. And we saw in the MRI that edema again started again to be quite wide. The cyst was not very much enlarged. We saw also that the cyst in the posterior fossa tended to enlarge a little bit compared with the preoperative imaging that we had before the endoscopic surgery, but there were no cranial nerves involvement. And because of the clinic, we decided for a supratentorial craniotomic cyst wall removal with complete clinical recovery. And histological diagnosis was a little bit unusual. It was the one of a bronchogenic cyst, and this was the sample that was out from our histological diagnosis. Then, based on these grounds, we followed up the patient that developed a subdural collection, and then she underwent a subdural peritoneal shunt. The edema was resolved, but after the edema, there was also a loss of brain substance around the cavity where the cyst was present, so probably there was already some loss of vascularization related to the inflammatory and compressive effect of the cyst that was present already before surgery. Then we did a follow-up MRI at 3 months. There was a slight further reduction of the cyst, but there was a an enlargement of the cyst in the posterior fossa with the appearance of a right seven cranial nerve deficit that was particularly clear when the child was crying. So based on our previous experience, we underwent suboccipital craniotomy and removal of the posterior fossa cyst that again showed to be a bronchogenic cyst. And this is the second histological sample. At least I would be curious if anyone of you did see a case like this. This is the follow-up MRI at 3 years now, with the cyst in posterior fossa almost disappeared, still the cavity with loss of substance in the supratentorial space. The patient now is no focal deficit, but she has developed epilepsy, which is becoming pharmacoresistant with a worsening neurocognitive developmental delay. And actually has entered in the protocol for epilepsy surgery. So just was the case that made me curious and go back to see what kind of cysts are bronchogenic cysts. They are part of the family of neuroenteric cysts. They are quite rare in infancy, especially the double location is quite unusual. Supratentorial lesions generally are extraaxial. Intraparenchymal have been described. I found only 2 cases in the frontal region, but all the cases tend to suffer of epilepsy and tend to become pharmacoresistant in the treatment of epilepsy. That's what we learned. Infratentorial are more common than supratentorial, and the most common location is similar to our one at the level of the foramen magnum, anterior anterolateral. And the only possibility for curing this kind of cyst is open removal of the cyst capsule, which remains the mainstay of treatment. And you need to long-term follow up these children to exclude recurrences. So unusual cyst with double location that made me learn to be quite cautious in considering, in any case, endoscopy for unusually appearing edematous cystic lesions, especially when they do have a double location like this case. So I'm curious to hear your comments about this case, if you had similar or other experience of this kind, and how did you treat these cases, and what was your follow-up? Thank you.
Thank you very much. I think it's a very rare case. I haven't experienced the bronchogenic cyst so far. Does it happen like this for the multiple location?
Well, if the question was, this is the only case I saw with a double location. We did see other cases of neuroenteric cysts, not bronchogenic, but this is the same family. The definition of bronchogenic depends from the kind of cells that the histologist found. So it's a neuroenteric cyst. So we did an experience of other neuroenteric cysts at the level of the foramen magnum, but never saw any neuroenteric cyst in the supratentorial space. So that was probably the thing that took initially our attention, because it was the most the largest cyst that we saw at the beginning with that edematous reaction, and pushed us to treat that one. And this was probably the way we passed through a different kind of vision of this case. So I did not have experience of other cases in the supratentorial space or multiple locations. This was the only case.
In case when you remove the schist wall, you need to remove the whole schist wall, or you can make a wide fenestration. Is that enough?
No, that is not enough. You have to remove all the cyst wall. It is not enough to open the cyst. It's not enough to, you need to remove the wall, all the wall. Otherwise, it has been described the risk of recurrence. This is quite well acquired nowadays in the literature. So did any of the other speakers have experience, especially Indian friends, about this neuroenteric cyst in the supratentorial space. Venkat or Sandip or anyone from...
Okay.
Very interesting case. I think the presence of edema is the cause of suspicion here. It's not neither an arachnoid nor a hydatid cyst. Obviously, it is a different cyst. So that would have been a clinical clue. Nevertheless, I think histology is the proof. And I never had a bronchogenic cyst, but had a cyst which is turned out to be a larva migrans, which is presented as a cyst with similar edema in the supratentorial location. A thick wall, we did initially thought as a non-pathological cyst like arachnoid cyst. Though edema was the controversial point clinically, we aspirated the cyst and left it off because cyst has collapsed. With an endoscopy, we inspected inside, nothing was found. And promptly the child came back with hemiparesis. So when he went back, did a craniotomy and excised the capsule. That turned out to be a larva migrans with a cyst. So, but we never had any neuroenteric cyst in the cranial cavity.
The multiple cysts in different location is another suspicion of, it's not an arachnoid cyst or something else.
Yes.
I think that would have raised some.
I agree on that, yes. In the first, we were pushed to treat what we looked to be a dangerous edematous cyst, so that's why we went on, also because we were not actually sure it was a tumor, like the radiologist was saying, and really we did not have experience of other kind of cyst in that supratentorial location. The low age of the patients also was considered, so we went in endoscopically first to take a sample. And also the first sample was misleading because probably from the part of the cyst that we took, there was only arachnoid and some neuroepithelial cells, but it was not a neuroepithelial cyst.
Absolutely right. Yeah.
I have had experience of 3 cases actually, 2 children and 1 slightly older patient in 20s. 1 at foramen magnum and 2 in posterior fossa, but no, none of them supratentorial. And not in infancy. They were all older children. I think youngest patient neuroenteric cyst is about 4 or 5 years old.
Thank you.
Okay, I think it's time to close this session. Thank you very much, Jean-Pierre.
Thank you, and
thank you, Andrew, for inviting.
Thanks everyone, especially I think our Japanese friends. It is beyond midnight. It's already 8th of January for them. So I'm really sorry for the odd times, but we had to suit everybody's time. And as expected, the discussion has gone a little beyond our expected time. I thank Nelsie for a great collaboration. Moody had to go away a little early because of some family emergency. But we would like to thank all the speakers, and we have had an overwhelming response with more than 400 participants on Zoom and several others on YouTube. We'll come to know only by, say, another 2 days or so. Earliest will be tomorrow. So I'll keep you posted. But thanks very much. And you can proceed, Nelsie, your final comments. And I think you have a meeting after that.
Yes, thank you very much. It was a great meeting, great opportunity to end our Pediatric Neurosurgical Committee work online, and really appreciate to see you all with this great discussion. The next step is try to work together, World Federation and ESPN, and maybe why not IFNI, with the course, and maybe collaboration, try to avoid clashing meetings and try to support each other. Will be a great opportunity to continue to work together. Thank you very much for being with us, and we have some people waiting for us in another room. If you would like to just switch, I put on the chat the new Zoom link with the password. We have already 10 people there waiting for us.
I would just like to thank the Health and You, the Digi company, which has actually helped us to conduct the meeting today and has helped several meetings of Pediatric and Endoscopy Society in India. Thank you, Mr. Deepak Naik, for the same.
Thank you very much. Stay safe.
Thank you. Have a good night.
Good night to all of you. Nice meeting all of you on the online. Have a wonderful year ahead.
Thank you. Great year, and hope we can get to Bogota. Yes. Some of us at least.
Thank you so much, sir. This is Deepak Naik on behalf of Health and You. Would like to thank for awesome display of knowledge, skills, technique, and technology. I am sure our audience must have really enjoyed the evening. And thank you for WFNS, the Pediatric Neurosurgery Committee, Neuroendoscopy Committee, conceptualized by Dr. Devpujari sir, Dr. Nelson Zenon, and Dr. Mahmood Qureshi. I would like to thank the audience also for being with us. They must have really found it very, very interesting and enlightening.
Good night.
Good night, sir. Sir, this webinar will be available in about 48 hours on our DG Neuro channel. And those of you who have missed the webinar or part of it can see it once again. And it will be available on DG Neuro YouTube channel forever for you to see. And more than that, you can have 60 plus webinars on this with 25 plus international speakers coming to you.
Thank you, Deepak.
Thank you very much, sir. Thank you. Have a good night and wish you a wonderful new year.
Good night.